Sir, you can see your colleagues here. Babu Rao and Bhagat.
Come from the UK. All of these people have become old. I am only still continuing young. No. Hello, Babu.
Oh, hello. How are you? It's good to see you.
You remember Kuti now?
Yeah, Dr. Shankaran Kuti. How are you? It's been a long time.
Because the thing is that Imran Khan, he called me Imran Khan. See who is there in the jail, Pakistan jail. I am still freely working in India.
Hello, Kuti. Bagdi here.
The problem is that you people happen to go abroad and in the higher institutions, whereas I came down to earth through the society, living as one among the society. That is how I became successful, and I am very happy. People are very much grateful to me, and they adore me just like an embodiment of God. That is the maximum advantage I got while practicing in my own native, poor, rural society. So, in fact, I enjoy the practice. And after that, the problem is that I may have a small house, but a lot of things which I am supplied on me or showered on me by God as well as my neighbors and my native people, they consider me as if I am giving them divine service. I don't know how much you can hear now, how much you have heard and understood. But anyway, I'm very happy. All are happy. Anyway, Barbara, very happy to see you now. Today
talk about Shankaran Kuti. Talk about our MS days, man. You're in alumni meet. 1974-77. Tell some stories.
Say that is what I was telling. Because
tell some stories about I.C. Verma. Hello. Tell some stories about Dr. R.A. Verma, Satya Prakash, Mehdi Datta, our classes.
Yeah. So that's one thing. First year when I joined, R.A. Verma, the terror of surgical field, was my professor. You remember?
We were there together, man. Unit 1.
And the thing is that, this is Bagdi. Bagdi. You see, I don't know who was talking, Barbara or Bagdi, who was talking, I didn't know.
Both of us are talking. He also talked, I also talked.
I asked you to come last week also. We could have had our previous 1 or 2 days time. Anyway, Bagdi are happy now, healthy now.
You know, that's why he could not come because of health issues. Otherwise, he would have come.
That is the only unhappy thing I am hearing. But anyway, happy at least I saw your face. Of course, I saw through the WhatsApp. That's right. But still, direct talk. I am happy in that way. And Babura changed relatively quite a lot. I feel. Is it not?
See, Babura always dreamt to be a liver transplant surgeon, and he did it. That is the great thing. He was there in Unit 3. He wanted to be liver transplant surgeon and he went. Great. I became pediatric surgeon because of Chatterjee's influence.
I know. Do you know this face?
Professor Anand Krishnan, Guruji, namaste, namaste. Good old days.
Where is the Jagdish?
Jagdish, we were there.
Because Jagdish was here with me. I got a lot of slap from him on the back as well as front because of our friendship. But anyway, that is also a pleasant and happy experience, Anyway, I came over here.
Shankaran Kuti, when we were in final year, this great Professor A.K. joined our unit. He came from All India Institute Medical Sciences and he screwed us up before we went for the exams. How much he trained us. I cannot forget. Fantastic.
Thing is that, see, these people are waiting for me. So I'll give the hand over this thing. This is a golden chance and a tricky chance I got to talk to you. Very much happy, very much thankful to you. I'll hand over the cake.
Hey Raj, where are you, man?
I am in Bombay, sir.
Where?
Bombay.
Why haven't you come down?
Some health issues, sir.
Okay, next year.
Yeah.
Hello, Dr. Ananthakrishnan. How are you?
Always remember you, sir.
Where's your daughter these days?
She's in Australia.
Okay.
Hmm.
Settle there, eh?
Yeah.
Okay.
We are starting in a few minutes. 1 minute, sir. They're bringing
Right.
them.
Thank you, sir. Dr. Vishnu, thank you very much.
Yeah, welcome, sir. Welcome.
Dr. Vishnu Prasad, it's a pleasure to meet you finally face to face rather than through emails. And thank you very much for organizing this and extending the invitation.
However, tell some stories about our batch, man.
Thank you, sir. I'm just
Yes.
both of you because we have to start 2:30.
Yeah. Yeah, little stories about our batch, though we are not there physically. It was a great.
I am muted actually.
अपने जाना कहीं पे मौका और छोड़ के दी दिल्ली जाके आई उसके बाद फिर अभी ये थोड़े दिन पहले थाईलैंड जाके आई थाईलैंड तो अपने 2 डॉक्टर के कपल्स को
Here we come. It is coming from here.
Good afternoon, everyone. Shall I start, sir? Good afternoon, everyone. On behalf of Department of Surgery, we welcome you all to the second JIPMER Surgery Alumni Meet.
मैं अपना कम पे करूँगी जो पढ़ना है
Okay. Good afternoon, everyone. On behalf of Department of Surgery, we welcome you all to the second JIPMER Surgery Alumni Meet, where innovation meets inspiration and collaboration fuels progress. It's a great pleasure and anticipation that I stand before you today to inaugurate this gathering of brilliant minds and visionary thinkers. Over the next few hours, we will embark on a journey of exploration, discovery, and exchange of ideas that will shape the future of our field. Our agenda is packed with insightful presentations, thought-provoking discussion to ignite transformative changes. I encourage you all to actively engage, share your insights, and seize the opportunity to learn from one another. To begin with, I request Dr. Hemachandran sir to enlighten us on the topic of minimally invasive valve replacement techniques. And I request Dr. Srikanth sir to chair the session. Thank you, sir.
So Dr. Hemachandran did MS from our department. Following that, he did MCH from JIPMER only. And he joined as a faculty in Department of CTVS. And initially, he was of great help to us when we started the liver resection in 2010. So, and along with him, we could progress further in the field of liver surgery. So we learned the technique of vascular surgery actually from him. So he was of great help and he has done a lot of work in minimally invasive valve replacement. So he will be describing the same now. Over to you. Dr. Srikanth is the chairperson for this occasion.
Good afternoon all. At the outset, I would like to thank the organizers for giving me a chance to present before my teachers my work on minimally invasive valve replacement. So as you all know, minimally invasive surgeries, like in other departments, like in heart, with respect to the cardiothoracic department, also it is available into a safe and effective option. There has been a significant recent paradigm shift in modern day cardiac surgeries, where many of the procedures are being undertaken with the minimally invasive approach. It has been proven to be a safe, reproducible technique with low postoperative morbidity and mortality, and the late outcomes are also equivalent to the conventional valve surgeries. So the heart lung machine was first invented by John Gibbon in 1950s. Since then, the heart surgeries have been routinely being done, but it took almost 40 years for the minimal invasive approaches to happen. So these minimally invasive cardiac surgeries can be divided either into epicardial or endocardial. And the epicardial surgeries being outside of the heart chambers, like coronary artery bypass surgery and epicardial lead placement. And the endocardial surgeries are basically valve surgeries, atrial fibrillation surgeries, and cardiac tumor excisions. Also, these minimal invasive cardiac surgeries can be classified based upon the length of based upon the length of incisions for the minimal invasive approach. Also, the mix can be divided into 4 different levels. As you can see in the level 1, the length of incisions are almost around 10 to 12 centimeter in length. When compared to the median stenotomy, conventional median stenotomy, the incision is around 15 centimeters. They are direct vision surgeries where you can access the heart through under direct vision. And level 2 surgeries are when the length of incision is around 6 centimeter. And level 3 incisions, when the length of incision comes down to around 4 centimeter, you need support of the camera system, and video assisted surgeries or comes at a level 3. And when it becomes less than 2 centimeter in length, where everything is totally port access, it comes under level 4 surgeries. Like any other minimal invasive surgery, the patient will have a faster recovery, improved cosmetic outcome, less bleeding and less arrhythmia chances, and it has proven to be a safe surgical option for patients with previous sternotomy, and there is definitely low degree of invasiveness with minimal invasive surgery. Whereas the disadvantages would be the duration of operation might get prolonged, and though these are technically demanding procedures with steep learning curves, and the reproducibility of the innovative techniques, and obviously the additional expenditure along with the minimal invasive approach are all disadvantages. But since 1990s, when the minimal invasive approach has begun, there has been a paradigm shift from minimal invasive approach even to micro approach, like less than 2 centimeter in length over the years, and therefore careful patient selection, appropriate surgical plan and selection of surgical approach are vital in determining the outcome following surgery. There are some, when you want to talk about the patient selection, there are some contraindications for patients to be planned for minimal invasive approach, like patient with obvious chest wall abnormality, or patients with any right-sided lung disease. There's going to be definitely lung adhesions, and therefore the thoracotomy approach might not be feasible for those set of patients. And also with patients with significant peripheral arterial disease, when the cannulation strategies would be like peripheral cannulation would be difficult, those patients are also relative contraindications. And a morbidly obese patient with a very deep chest, where the anteroposterior diameter is going to be more, approaching the valve at such a depth might be difficult, maybe a relative contraindication, and sometimes it might be technically demanding when the calcium starts involving the annulus, mitral annulus. Then again, minimal invasive approach might be difficult. Those are relative contraindications. So, considering all these factors, our aim is to minimize trauma to the patient, but still we need to maintain safety for the patient. Safety in the sense for cardiac surgery can be divided in all these following 4 domains. Like first is safe establishment of the cardiopulmonary bypass with safe cannulation techniques. Next would be a myocardial protection with a suitable cardioplegia delivery technique. And then the surgical exposure with a minimal invasive approach is also crucial. And finally, to wean the patient off the cardiopulmonary bypass, all those things should be carefully taken care of so that patient safety is ensured. So I just want to brief you on the conventional valve replacement CPP strategies. Like a cardiopulmonary bypass is where we bypass the heart and lung. The work of heart and lung has to be bypassed. So the venous blood returning to the heart are drained into the reservoir. It is getting oxygenated and it is pumped in through the aortic cannula into systemic circulation. Then we divide the systemic and coronary circulation with the aortic cross clamp. Then a cardioplegia is delivered, which ensures cardiac protection. and then we do the surgery. Then patient has to be safely weaned off bypass. As shown here, you can see the aortic cannula in the ascending aorta. Then this is the cardioplegia cannula in the aortic root, and this is the venous cannula in the superior vena cava, and this is the venous cannula in the inferior vena cava. And this is the cross clamp applied to separate systemic circulation. As you can see here with your full median sternotomy, the whole heart is in front of your eyes with all the great vessels and the heart chambers. And after arresting the heart, we expose the mitral valve by retracting the left atrium. Again, the exposure is beautiful. And in the aortic valve, after aortotomy, the aortic valve is very much visible under the surgeon's eyes. And also after finishing the valve replacement, when you come off bypass, sometimes there can be rhythm disorders. Patient can have ventricular fibrillation, where you can safely apply the internal paddles to defibrillate the heart, and also you can have full control of the heart chambers. We won't allow the heart chambers to distend, and you can easily de-air the heart. All are very simple in case of conventional strategies. Whereas in mixed strategies, mixed valve replacement, you approach by right anterior thoracotomy. Again, the cannulation is going to be difficult. The ascending aorta is going to be deeper. Then you are going to choose for peripheral cannulation. You take the help of femoral artery or femoral vein, or the axillary artery or the internal jugular vein for peripheral cannulation. And a long aortic cross clamp might be required, which can be introduced from the right lateral chest wall, which is called as a Chitroot clamp. Then a long cardioplegia needle will be required to give the cardioplegia for arresting the heart. You do the valve replacement. Surgical exposure is really challenging. Then while coming off bypass also, to wean the patient off bypass, again, it is going to be difficult. You need to have a control with transesophageal echocardiography. You have to look at the LV function, and you won't be able to de-air the heart properly. Then you require carbon dioxide insufflation to prevent arterial air embolism, and requirement of external skin paddles also involved. You won't be able to apply internal paddles if the patient develops ventricular fibrillation. You need to already position before prepping the patient itself. You have to keep behind the skin pads to cause defibrillation. So all those things are difficult strategies when you are opting out for minimally invasive cardiac surgery. And anesthesia strategies are also difficult. When you are approaching thoracotomy, you need a single lung ventilation. W ventricular tube is required. Then anesthesia should be well versed with transesophageal echocardiogram, and anesthesia also should be well versed with cannulations by Seldinger technique. For sometimes endovascular cannulation has to be done under ultrasound guidance by the anesthetist. So these are all the various equipments required by the anesthetist: the W endotracheal tube, the external skin paddles, and the TE probe. So role of TE in mix is very, very crucial, because careful position of the venous cannula or the arterial cannula in the system, guide wire has to be ascertained in the proper place, and use of endoaortic occlusion balloons for everything. TE guidance is very crucial. And as I already said, you won't be able to look at the heart itself, the whole of the heart. You will just be able to see the exposed valve, and hence the assessment of LV function, assessment of the replaced valve, everything. For everything, TE is very, very crucial when you go for minimally invasive cardiac surgery. The perfusion strategies also is very important. Like when you place a percutaneously guided venous cannula, sometimes drainage might not be adequate. You might need to augment the venous drainage. You require extra support like vacuum assisted venous drainage or a kinetic venous drainage, and the pressure has to be regulated. It has to be maintained around -30. You need special cannulas. All these gadgets are very much essential for minimally invasive cardiac surgeries. A long femoral arterial cannula, and the venous cannula, as you can see here, introduced to the femoral vein. It is a multi-stage venous cannula. The lower holes are used to drain the inferior vena cava, and the upper holes here will drain the superior vena cava. So even when you put the LA retractor, it hits against the venous cannula. It might hamper drainage, but here in these types of cannula, it might not be so, because the multi-staged venous cannula will allow continuous venous drainage to happen easily. So coming to the mixed approaches per se, there are multiple approaches for individual diseases. For coronary artery bypass surgery, left anterior thoracotomy. For congenital, various other incisions. Now we will be concentrating only on the minimally invasive approach for the valve surgeries. So as you can see here, patient is positioned supine for right anterior thoracotomy with a 30-degree elevation of the right lateral chest wall with the help of sandbags down. So for minimal invasive mitral valve surgery, the two most preferred incisions for minimal approaches would be the right anterior thoracotomy is the most preferred minimal invasive approach for mitral valve. It is mostly we approach the heart by the fourth space. We collapse the right lung and open the pericardium. We reach the heart. And the other approach for the mitral valve is the lower hemisternotomy. As you can see here, the incision is the orange one is the skin incision. The which is represented in the dotted lines is the incision of the sternum. You start from the xiphisternum down and go up across the second space, across the Lewis angle. Another recently tried approaches are a circumareolar incision. You see the incision around the areola, like in the totally port access type of minimally invasive approach, mitral valve replacement can be done. So for the aortic valve per se, we have many different approaches. The most commonly used are these two, the right anterior thoracotomy and the upper J sternotomy. For the mitral, I told you lower J sternotomy. For the aortic valve, upper J. So it's depending upon based upon the position of the ascending aorta. When the more than 50% of the ascending aorta is to the right of the sternum, then you can go by right anterior thoracotomy. And when it is less than 50%, like most of the ascending aorta is in the midline, then you have to go via the upper J sternotomy, where you cut across the third or fourth space. And as seen here, the incision is of the sternum, starting from the sternal notch across the third, fourth space. The skin incision will be much more lesser in size. The previously described approaches were parasternal approach, where the second and third cartilage are excised and the aortic valve is approached. Coming to the cannulation strategies, either we can adopt for a central cannulation strategy or a peripheral cannulation strategy. As you can see here in the picture A, it is a right anterior thoracotomy for the aortic valve, where it's approached the second space and the aorta is cannulated through the incision itself. And even for mitral valve, as you can see, this is a cross clamp, signet type cross clamp, and this ascending aorta cannulated and the right atrial appendage cannulated. But we go for mostly peripheral cannulations because central cannulations may be riskier to approach the aorta at so much depth. So we go for peripheral cannulation strategies, where IJV is cannulated percutaneously with the help of ultrasound here, and a femoral cannulation of the femoral artery and femoral vein to establish cardiopulmonary bypass. These are the various instruments used for minimal invasive cardiac surgery, all long instruments from knot pusher to valve holder to the LA retractor with these are the LA blades used for retracting left atrium. And aortic occlusion clamps are also longer, different types of aortic occlusion clamps used. And for cardioplegia delivery techniques, you need a long cardioplegia needle, and sometimes through the in port access surgeries, when the incision is going to be less than 2 centimeter, endoaortic occlusion balloon is used to cause an aortic occlusion and also to deliver the cardioplegia. So after you arrest the heart in minimally invasive approach, as you can see here, as wound tissue protector is applied, and these are the retractor blades in position, and this is the mitral valve in position getting implanted through the incision. And this is a mini sternotomy approach for the aortic valve, where you can just see the ascending aorta, valve is excised and the valve is being replaced. You cannot see anything else, any other, either right ventricle or left ventricle cannot be seen at all. So before you come up bypass, you need to get ready for the closure also, because you won't be able to approach the right ventricle. If you want to take a pacing wire, you have to take it when the arrested heart itself. Even placing a chest drain has to be placed when the heart is arrested. So this is the position of when you do a minimally invasive approach, the surgeon stands, it's on the right side, the perfusion is opposite to the surgeon, and the anesthesia is on the head end. Recently, transcatheter aortic valve implantation also has given more popularity, wherein it is totally aortic valve is replaced with a percutaneous route. Either it can be by transfemoral route or transapical route. As you can see, a mini thoracotomy is done, and a pursing is taken in the apex of the heart, and aortic valve is implanted. And this is a transfemoral route wherein the aortic valve is deployed when the heart is getting fibrillated. So this is schematic representation of the whole system, wherein the valve is directly implanted into the aortic valve. So because of all these things, now the Indian Association of Cardiothoracic Surgery has come out with a separate association, like Indian Association of Interventional Cardiac Surgeons, where the cardiac surgeons also should get trained in wiring skills, and they should be well versed with all these implantations. So a separate course has also been recently organized under the aegis of Association of Cardiac Thoracic Surgery, Indian Association. So this in brief about the minimally invasive valve replacement. I would like to brief you upon our JIPMER experience too. This is a study which was funded by SERB for 50 lakhs they funded, from which we could purchase the minimally invasive instruments, and we started doing minimally invasive procedures from 2020 onwards. This comparison of conventional single valve mixed valve replacement for early and long-term outcomes, a randomized open-label trial. So around 150 patients were screened and 130 were randomized, and 66 in the conventional arm and 64 in the minimal invasive arm. Around 66 out of 66 median sternotomy patients underwent median sternotomy, 53 were underwent mitral valve replacement and 13 underwent aortic valve replacement. 51 underwent minimal invasive mitral valve replacement and 13 underwent minimal aortic valve replacement. There was 13 conversions from conventional group to mixed arm, and the pain score was assessed by visual log scale in the immediate post-operative period, and the outcomes also assessed, and the late outcomes at 6 months also assessed during OPD follow-up. Coming to surgery protocol, in the conventional arm, all underwent median sternotomy. In the mixed minimal invasive mitral valve arm, they underwent right thoracotomy, and aortic valve minimal invasive underwent mini sternotomy. Anesthesia protocol is the same: double lumen tube for the mixed arm and the conventional single lumen tube for the conventional arm. All the medications, anesthetic medications are similar between both the groups. The patient with unconventional arm and cardiopulmonary bypass instituted with aortic bicable bypass and femoral bypass for the mixed arm. So these are the various incisions we did for the patients. On the there were basic demographic factors were matching between both the groups, but the cardiopulmonary bypass time was significantly longer for the minimally invasive arm, whereas the other parameters like aortic cross clamp time, the time to extubation, the ICU stay, time to discharge were similar between both the groups. Even the blood requirement for both the groups was similar. And but the pain assessment in the initial 2 days was the pain score assessment was similar between both the groups, but on post-op day 3 there was significant difference. The minimal invasive arm has a lesser pain score compared to the conventional arm, and at 6 months follow-up, still the chronic pain assessment, it was more in the conventional arm and it was statistically significant, and there was more propensity for keloid formation and hypertrophic scar formation for the conventional arm patients. So these are our patients who had more keloid formation. The median sternotomy patients who underwent median sternotomy had a more keloid formation. These are our patients who had minimal incision, thoracotomy incision for mitral valve replacement. Their wound healing was better, though some of the patients had hypertrophic scar and keloid. Out of 64 patients of minimal invasive arm, 13 patients converted to median sternotomy due to various reasons. 10 mitral valve patients were converted into minimal invasive arm, 3 due to difficulty in peripheral access due to atherosclerosis, and 1 due to difficult exposure of mitral valve, we had to convert into conventional sternotomy, 1 due to heavy load of left atrial thrombus, which was difficult to remove in toto through the minimal invasive arm, and 4 patients due to severe pulmonary edema due to various anesthesia indications, we had to convert into a mixed arm. And for the aortic valve replacement, 1 patient had an uncontrollable aortic root bleeding. Finally, we had to convert it into full sternotomy. And 1 patient had again high calcific load of aortic valve. And 1 patient had refractory fibrillation, we had to convert into for full sternotomy. So out of 130 patients, 3 patients expired. 1 patient on follow-up in median sternotomy after 1 month of surgery. At home, she has expired. 1 patient who was converted to median sternotomy because of high PCO2 levels had a sudden cardiopulmonary in the ward. And 1 patient, the aortic valve replacement underwent median sternotomy, also died. There were no re-explorations, no peripheral access related complications. And 1 patient in the minimal invasive mitral arm had a paravalvular leak who underwent a redo paravalvular repair after 1 year of surgery. On 1 patient, the minimal invasive mitral valve replacement patient had a severe LV dysfunction, immediate post-operative period. She's on follow-up now and she's her LV function has recovered. There is no incidence of cerebrovascular accidents, no incidence of mediastinitis or thoracotomy site infections. There was some significant learning curve. In the first initial 30 patients, the cardiopulmonary bypass time aortic cross clamp is longer when compared to the last 30 patients. And also the bleeding was considerably lesser in the last 30 patients and the minimal invasive arm. So to conclude, on minimal invasive valve replacement associated with better short-term outcomes in terms of less post-operative pain and better long-term outcome with lesser keloid formation compared to the conventional approach. The complication rates and mortal rates of MIV are comparable with the conventional approach. Based on the experience we have gained, we organized one hands-on training workshop on cadavers in collaboration with the Department of Anatomy. We had delegates from all over the nation, and this was a workshop team and some workshop photos. Future plan would be to proceed to level 3 surgeries with video assisted and total endoscopic valve replacement, and also to expand doing minimal invasive approach for coronary artery bypass surgery, and in long term to start a fellowship in minimal invasive cardiac surgery. Thank you, the organizers and Vishnu sir, especially for giving me this opportunity to present my work in front of my teachers and friends. Thank you.
With the appropriate people to comment, Dr. Rajesh.
Yes.
Direct vision or do you use
Still, we direct vision only we are doing. We have to. We have a robot, so now we are doing robothoracic surgery. Robot, correct. Thank you. Thank you.
Pediatric cardiac work are you doing on? Usually mix starts off with ASD, you know.
ASD, yes.
So
ASD we close by mix.
Achha.
But we have not expanded it to VSD, no? Only ASD we are doing by mix.
Okay. Because some have started doing tetralogy, transannular patch,
yes, sir.
with the right ventriculotomy.
And but that's the only they cannot do a valve sparing. They cannot spare the pulmonary valve in it. So I think the first level is usually ASDs, then they progress to valves.
Yes, sir.
But anyway, good job, and I think you have done quite well on that.
Thank you, sir. Thank you.
What was the primary outcome of the trial?
Primary outcome is immediate post-operative outcomes will be the pain score and the time to discharge, time to extubation. All those are the primary outcomes. Only pain was that a significant difference. Conversions. Yes, sir.
Curious to know, because in abdominal surgery, the at least in the area of colorectal, this has been looked at. If you have a conversion, then that subgroup seems to fare worse than open surgery. I mean, when you look at laparoscopy, open, and laparoscopy converted to open. So what is it here?
Actually, many patients conversion means it was before even they are get allotted into the thoracotomy arm, but because of various other issues, they got converted into sternotomy arm without even before the incision itself. Only 2 patients had to be really converted after the thoracotomy incision. Rest all were converted prior because of anesthesia problem, and final analysis was done based on intention to treat analysis.
What is it based on? Larger experience or experience outside? Do these patients fare worse, the ones converted?
Convert in the middle of the procedure. And started as a minimal invasive and you have to convert, then they definitely do, because you have a complication like a massive bleeding for which you convert, then they definitely do worse than
conversion in mini sternotomy to full sternotomy may not be a big problem. Conversion to thoracotomy to sternotomy may be a big problem. When there's annular involvement, then it becomes more technically demanding, or small aortic root may not be manageable by a minimal invasive approach. We have to get converted into it.
What do you do for the post-operative pain? Do you infiltrate them intraoperatively? Do you do a intercostal block?
Intercostal
or do you use a
block.
cryoprobe?
Initially we were giving, but later we stopped giving. Patients were doing well with paracetamol and tramadol infusion alternating. They were doing good.
Do you have a cryoprobe? That is one option where you can put a cryoprobe. So for 3 months there'll be some paresthesia, but the pain is quite less.
Thank you. Thank you, sir. Thank you.
Wait a minute. There's a moment to you by the chairpersons.
Hello. Now I request the chairpersons to facilitate Hemachandran sir with memento.
Keep it later. We'll keep it. So next we have a short talk by Dr. Shankaran Kutty, who is from the Golden Jubilee batch of 1974. So I request you, sir, to be very brief and only 10 minutes available because we're already running short of time. Okay, please.
Hello, Dr. Shankarankutti. Probably the only one Golden Jubilee student from Kerala. I did my MS in Pondicherry JIPMER as the first batch of entrance, PG entrance. Out of 6,800 applicants, 600 were called for exam. Out of which 60 were called for interview after the exam. Then I got the 3rd rank and joined for MS. First under Dr. R.A. Varma. Next, Dr. Satya Prakash, probably the name here in the board. I was one of the most happy students out of the 6, all from all over India. And we had a very nice, very happy, pleasant life in JIPMER, Pondicherry, 74, 76. Now, one senior person I can see here is only Dr. Smiles. I want his blessings also. After my MS, though I had lot of offers from US, I decided that I should render my service to my native people. The outcome was not important, but the satisfaction of the mind that I am doing the service to my native poor people gave me lot of appreciation in my mind. Still continuing, during my work in general surgery, initial stage there was no anesthetist to help at all in the government service. Spinal anesthesia I had to do myself. General anesthesia open either with the support of my sisters, senior sisters, mastectomy, thyroidectomy I had to do. But I was enjoying those days because whatever be the challenges, I could continue my service to the society. A day I was doing 60% of gynec and obstetrics works, so that I was compelled to take up a DG also. For the last 45 years and more, in my native place, I am serving to the people. As a general practitioner, giving diarrhea, upper respiratory infection, and headache treatment at home, and giving treatment for surgery and gynecology and obstetrics in the hospitals. People are very much thankful to me. And in fact, out of their compulsion only, I wrote my experience as a book in Malayalam. When I was compelled to, or rather threatened by Vijay Kumar that I should come here for this meeting, then I thought I will take up one of the copies of my Malayalam, which was not published at all. This is in Malayalam. I wanted to give it to Vijay Kumar or the surgery authorities to be kept in the library. And a small booklet like English version also is written. That 3 or 4 copies I will give it to. I think Smiles is the best person to give it. Because my senior, 1 year senior at least. So to Smiles also I'll hand over it. And all of you bless me to continue my gynec, general surgery and general practice work in my native place. And thank you for giving me an opportunity to do this. Who is coming first? Vijay Kumar, either of you. Yeah. Anyone, I'm happy to give to be supplied in the library for reference. That is one thing. This is Malayalam version. Malayalam version. Front and back page. One more.
I'll take this.
This
I'll
is
take
this one. This is it. One more. This is English. Greatest and capital in my time.
Thank you very much, sir.
This was- I don't know whether those things were signed into this. And
Yeah, yes. So next is your bashment lecture.
Okay.
So next we have the online lecture by Baburao Kune from the Golden Jubilee batch. For this, the chairpersons, myself, Rajesh and Rajnikant, kindly come over here. And the topic, let me introduce. Oh, yeah. Sorry, I forgot to give a moment to So let me introduce Baburao Koner. So he is from the 1974 batch. After his MS, sir went to do his 1 minute. He went to Coimbatore as a senior registrar in cardiothoracic. From there he So from there, he moved out to East Birmingham Hospital, UK, and from there to USC. From there, he went again moved on to Groby Road Hospital, UK. From there, he moved to USA, and there he got the postdoctoral fellowship in Pittsburgh. And following that, sir is in the worked in the transplant surgery for a long period, and he was the professor of transplant surgery, and recently only he is retired from this services. So, are you there, sir? You can start.
Yes, can you hear me?
It is difficult to comprehend this CV. It's got innumerable number of papers and grants. So I find it difficult to comprehend in this.
Are you able to hear me? Hello? Hello? Are
Yeah.
you able to hear me?
Yeah, we can. You're audible, sir. You can.
And you're able to see my slides, right?
Make it big.
You're able to see my slides? Hello?
Yeah.
Are you
Vijay.
able to see my slides? Hello? Hello?
Thank you all. So we can start the session, sir.
Okay, are you able to hear me and see my slides?
Sir, can you increase your volume a bit so that it is clear here? It's low in volume.
Okay, how about now? How
Just
about now?
can we have it a bit higher, please?
I think I'm full volume on my speakers. Is that okay better now? Hello?
So the volume is not clear.
I don't know what else I can do. The volume is 100% on my speakers, and I'm not doing anything different than my usual presentation. So, shall I start speaking, or there is a problem in people hearing me? Hello?
Please go ahead with the talk, sir.
Okay. Good afternoon, ladies and gentlemen, and it's been truly a great pleasure to see my former colleagues, Dr. Bagdi, Dr. Pudi, and my former teachers, Dr. Anantakrishnan. And I also heard through other comments, Dr. Smiles is in attendance, and I want to say hello to Dr. Smiles. And certainly, I want to thank Dr. Vishnu Prasad for organizing this and for the invitation. So my talk today is liver regeneration from a myth to the clinic. I'm having trouble advancing the slides. I'm not sure what's going on with the slides. They're not advancing. Or my slides are not advancing.
So you can go on.
Okay, are my slides, they're not advancing?
Oh, slide. What is it telling? Okay. Hello, share.
No, I'm only sharing the PPT. So some problem from that side. So option for multiple person can.
Okay, how about now? Okay, so I'm sorry about all these technical problems, but my purpose today is to cover briefly liver regeneration from its Greek mythology to what is clinically important. I think a lot of those. Can I continue? Can I continue?
Yeah. Please go ahead.
Okay. I think most of us in some form or the other have heard the Promethean legend, which goes as follows. Prometheus, who was a Greek, stole the fire from the chief of the Greek gods, Zeus, who got very upset at this travesty and chained him to a rock and commanded an eagle to peck at his liver every day, only to see that the liver regenerated overnight. And so Prometheus continued to live on and eventually to be liberated later. I think liver regeneration could be considered in essence as under the control of a hepatostat, just like, say, a thermostat controlling the temperature in a given room. The hepatostat is not a center like a center for temperature control, etc., but it's a coordinated set of biological programs whose goal is to maintain normal liver and body weight ratio. So following hepatectomy, there is onset of liver regeneration. Its progress is monitored, and upon reaching a certain homeostatic level, the thermostat shuts off the liver regeneration and liver weight is maintained. Several animal models are available for studying liver regeneration. Small animal models such as mouse and rat provide cost benefits, tremendous benefits with the availability of various knockout strains. And those who have done research know that it's a lot easier to get various laboratory reagents for rat and mouse. But the findings from them are not as translatable to humans as studies in larger animals. And among the larger animals, as far as liver surgery is concerned, pig is considered an ideal large animal model. How liver regenerates depends on the volume of liver that is lost, of course, for us as surgeons through liver resection. When the volume of loss is minor to moderate, the regeneration occurs essentially from an increase in the size of the cells without really the cell number changing. So the cell cycle doesn't progress towards mitosis. On the other hand, when a greater proportion of liver is lost, say, as after a right lobectomy or an extended right lobectomy, hypertrophy alone would not be sufficient, and the resting hepatocytes have to go through cell cycle progression leading to hyperplasia. On average, the studies show that cells undergo anywhere from 1.5 to 2 cycles of mitosis under these conditions. And even further, when 80 to 90% of the liver is lost for various reasons, then the available liver cells are not sufficient, and then the organism depends on the biliary epithelial canalicular cells dedifferentiating into liver progenitor cells, which go on to various cell lineage and then redifferentiation in the process. Various component cells have different dynamics. This showing that hepatocytes are the earliest to enter the proliferative cycle, peaking at about 24 to 30 hours and gradually dropping off to its baseline by 72 hours. Kupffer cells are the last ones to reach and peaking around 72 to 96 hours and are the last ones to become quiescent. While it's not exactly known what initiates or triggers liver regeneration, the conventional beliefs at this point, with some evidence, of course, is that it is the increase in portal blood flow to the residual liver that induces sinusoidal and hemodynamic shear stress, leading to a cascade of events. And in addition, there is increased delivery of nutritious and growth factor compounds from the splanchnic circulation, such as insulin, nitric oxide, so on and so forth. While portal blood flow takes center stage in liver regeneration, arterial flow remains on the sidelines for the most part, remaining unaltered, except, of course, when there is arterial compromise that impairs liver regeneration. I think this is most notable in the small number of patients that develop small for size syndrome following live donor transplant, where arterial vasospasm plays sometimes a key role in the pathophysiology. In this one slide that I have to briefly mention the mechanistic underpinnings behind liver regeneration, the essential event that occurs, of course, is the transition of hepatocytes, where almost all of them during normal state are in phase G0 to progress to G1 and subsequently to S phase and then mitosis. Important in this mechanistic transformation are mitogenic proteins such as hepatocyte growth factor and epidermal growth factors, and then non-mitogenic cytokines such as TNF, IL-6, catecholamines, bile acids, and insulin. And there is a tremendous amount of cell-cell crosstalk between hepatocytes and the various non-parenchymal cells with interchange of growth factors such as HGF, TGF-beta, and then transcription factors such as NF-kappa B, STAT3, and beta-catenin are involved in addition to cell cycle facilitators such as cyclin D1, etc. When all is said and done, and when liver regeneration has reached a homeostatic level in experimental animals such as rodents, it often happens by day 7. There is a downregulation and the hepatostat exerting its moderating influence and coming back to status quo through various cytokines such as TGF-alpha and beta, and transcription factors such as CAAT enhancer binding protein, and components of extracellular matrix such as integrins and other derivatory products from collagen. In all of this, there is this a pathway called HIPPO, YAP protein and TAS protein pathway that is believed to be important. Of course, all of us very well know as clinicians, especially if you are a liver surgeon or a hepatologist, if the liver regeneration is impaired for whatever reason, there is postoperative liver failure with its adverse consequences of increased hospital resource utilization, and most importantly to us as clinicians, increased 30 and 90-day mortality. What are some of the impediments to liver regeneration? I will touch upon 3 of them. One is, of course, portal hypertension, which is often present in patients that come to liver surgery, especially hepatocellular cancer. And a sample data that I'm showing you today is in taking patients with postoperative liver failure, in this instance, defined by the 50-50 criteria. And if you see patients on the right-hand side of that box box data, you see the liver failure group having a significantly higher portal pressures of 22 millimeters of mercury in comparison to those with without liver failure, wherein the portal pressures are normal. Of course, the portal pressures are the causatory factor in the liver failure and not vice versa, liver failure causing increased portal pressure. Although in small Forsyth syndrome, this could happen. The second adverse impactor on liver regeneration is hepatic steatosis, which is often present in obese patients and, of course, alcoholic liver disease. This sample data shows a case-controlled study of 84 patients of obese and non-obese patients subjected to liver resection. To begin with, the obese group starts off with a much larger total liver volume due to hepatomegaly with liver steatosis. But most important in the slide, I would like to draw your attention is to the second and the third paragraph of data, where you see the 1 month and 6 month remnant liver volume divided by total liver volume. You can see that in the obese group, it is significantly inferior to the non-obese group at 66% versus 74% at 1 month and 71 versus 82% at 6 months. The final adverse impact on liver regeneration is advancing age, which through cellular senescence process affects cell cycle progression via accumulation of inhibitory proteins such as P21, P16. And also there is increasing recognition that senescence is associated with a secretory profile, so-called SAS profile, comprising of increased levels of pro-inflammatory cytokines, IL-6, IL-1, chemokine, ligand, and insulin growth factor binding protein 3. We also know that age is often associated with substantially increased prevalence of obesity and diabetes. And all of these clinical problems share certain common pathways in their eventual impairment of liver regeneration. We have a couple of options to determine the size of the liver that will be left behind after surgery. Although there is substantial literature about potential use of indocyanine green, exhaled carbon 13-3, etc. However, they have not reached clinical fruition, and except in studies, very few centers use it. And if so, most of them are in Japan, etc. So by and large, us as clinicians, we depend upon volumetric determination on a CT, either by manual or computerized methods. If we are concerned that the patient doesn't have sufficient future liver remnant prior to doing liver surgery, or we are concerned that liver regeneration may not be optimal, then options at our disposal are to promote liver regeneration a priori before we do surgery through various modalities. Predominant among these are interventional, principally comprising of portal vein embolization, and more recently, and in a smaller number of cases, combining it with either sequentially or at one time of hepatic vein embolization. And in the last several years, there is increasing use of transarterial radioembolization for both primary and metastatic tumors with yttrium-90. Of course, in circumstances when interventional radiological approaches are not available for whatever reason, then one has the option of surgical ligation of the portal vein, although it is being done less and less. And finally, I will briefly touch upon the ALPS procedure, which actually makes us think that maybe by this mechanism, we are mirror imaging the Greek myth of liver regenerating in a prolific manner. So how does one assess liver regeneration? It is by two tools. One is the so-called degree of hypertrophy, which is essentially derived by future liver remnant volume divided by the total liver volume after the treatment, such as portal vein embolization, and subtracting the baseline value from that and expressing it as a percent, say 5%, 10%, 15%. Usually 15% is considered desirable. However, studies have shown that it is not as good predictor of postoperative liver failure as the kinetic growth ratio, which is being increasingly used. Kinetic growth ratio is nothing but degree of hypertrophy divided by the elapsed time after the intervention to promote liver regeneration. Usually it's in weeks with portal vein embolization, and it is in days with ALPS. Here are a set of sample slides showing right portal vein embolization, usually performed via a ipsilateral percutaneous approach and with the utilization of either coils, as in this case, or more often these days with microparticles or glue. On the right-hand side, you see a case of combined portal vein and hepatic vein embolization. I must confess, I have very little experience with the combined vein embolization, although our center is embarking on doing it on select few patients. Transarterial radioembolization induces liver regeneration in the untreated areas by causing atrophy of the treated hepatocytes. The liver regeneration is slower, of course, therefore takes longer. The kinetic growth rates are substantially lower, well under 1% at a median per week. Interestingly, the kinetic growth ratios, at least in some studies, such as the one that I'm citing for you today, has been similar in cirrhotics and non-cirrhotics. Finally, the surgical approach to inducing liver regeneration is the association of liver partition with portal vein ligation and stage hepatectomy. It's certainly used a lot more in European centers than in US centers, but it is steadily increasing in its adoption in American centers too. I will show you just one set of data regarding ALPS procedure. It's a multi-center RCT from a group of Scandinavian countries of approximately 100 patients, half of them randomized to ALPS and the other half randomized to two-stage hepatectomy. You can see here ALPS was significantly more successful in achieving resection, which is the first row in this data set, 92% versus 57%. And 13 of those patients from two-stage hepatectomy group eventually were crossed over to ALPS to achieve resection. Although the initial mortality rates of ALPS were higher in the range of 15 and in some centers 20%, these days mortality rates of 9% are being reported. The complication rates are similar. What I'd like to highlight your attention is the second row of data from the bottom showing kinetic growth rates of 14% in 1 week in comparison to two-stage hepatectomy. And more recent data show that actual kinetic growth rates with ALPS are anywhere around 7 to 8% per day. That here and there I mentioned earlier, maybe science has finally, I wouldn't say achieved, but at least is approaching the Promethean legend of liver regeneration. And I just have a couple more slides. On a optimistic note, to give us an idea of what is on the horizon is senolytic therapy to abrogate the inhibitory effects of age on liver regeneration with utilization of small compounds. In this case, in a mouse model, you can see on your right-hand side at day 7, the liver is substantially bigger than with control DMSO. And in summary, therefore, ladies and gentlemen, understanding liver regeneration is clinically important for the sake of choosing patients better for our liver surgery and better utilization of clinical tools to promote liver regeneration where it may not be considered optimal. Of course, our final goal is always improving our patient outcomes and therefore raising our confidence in offering liver surgery to more patients, with the expectation that new therapies are on the horizon, such as senolytics, and possibly even with the arrival of GLP-1 agonists, they may have a role in reducing hepatic steatosis and making surgery safer in such patient subgroups. This has been a wonderful opportunity to present this, and it's truly a privilege. And thanks once again to Dr. Vishnu Prasad and the organizers. Thank you.
Thank you, sir. Thank you for the wonderful talk. And in fact, the liver regeneration, you have covered the liver regeneration as a whole and how it is useful now. Liver regeneration per se has increased the resectability of HPB oncology, any benign tumors, as well as liver transplant. In fact, the concept of living donor liver transplantation is helped by this concept of better understanding of this liver regeneration. And as Dr. Barbara said, that it's about understanding the portal hemodynamics, how you deal with it. The more and more the current concept goes, how you modulate the portal flow to get the patient who was undergoing major liver resection to get them out without having a post-hepatectomy liver failure. So has his slide, one of his slides shows which are the cells which regenerate first hepatocytes, cholangiocytes, and then the sinusoids. The same thing in your LFT. When you see the post-op, the INR settles down first. Then it takes time for your bilirubin to come down, and then your ascites comes down, especially in a patient who goes for a major liver resection. So he has elaborated nicely all these factors. I would like to ask you a question, sir. What do you feel the role of portal pressure and flow in understanding the liver regeneration, how you modulate it currently?
There have been some data in the literature about measuring portal pressure as wedged hepatic vein pressure, which of course is the sinusoidal pressure. Prior to liver resection in patients that we are concerned about, of course, those with cirrhosis. And we have done that in some of our patients, but we run into practical problems in having these studies done. It is additional procedures. And what we found is that the measured pressures in the interventional suite are often not very reliable when we measure them in the operating room. So on theory, it certainly makes good sense, but in practicality, we found it's not very reliable. I don't know. I'd like to hear if you have some experience in JIPMER utilizing this approach.
So our experience is like when we do a liver resections, we when we intraoperatively, like if you're not able to modulate it preoperative, intraoperatively we find the pressures are high, which is a surrogate marker that you are going to face a portal hyperperfusion. We try to modulate by doing a splenic artery ligation or a shunt depending on the magnitude of the portal pressure, and then try to have a portal flow that is not to overshoot the hyperperfusion. So we try to have a pressure around less than 14 at the end of the surgery, portal pressure, to have a smooth post-op course. We have tried this in few patients and then it's worked. In addition to it, in the post-op we do pharmacological modifying like terlipressin, octreotide to help to reduce the portal flow. And as you said, arterial flow, when you do a major liver resection around 80%, when the portal hyperperfusion is so much, the buffer response causes an arterial insufficiency, which actually tilts the balance to death, the mortality, increasing the mortality. So splenic artery ligation here, it helps to increase artery flow, and then we find that may be an advantage.
Great.
Yeah, thank you. Thank you, sir. It's a very nice overview in liver regeneration. Just to a small question. Currently, are you using any medication to improve the regeneration in your models or in your practice?
In clinical practice, no, I have to say no, we're not using any pharmacological agents. No, my answer. And I mean, if you have some experience with such use, I'd like to hear them.
Thank you. As Rajesh said, LDLT is basically modulating the portal flow, inflow, and modifying it. It's mainly for recipients who is very sick and final high MELD score patients. We regularly do check the pressures and modulate the portal flow. It has to be the portal, the sinusoidal shear has to be adequate. It should not be very low. It should not be very high. It has to be optimal for the regeneration. So still a lot of experiments and this research going on. What is the ideal way to regenerate? And the LDLT concept, living related donor concept, is entirely based on the liver regeneration. Cadaver transplantation is the other way. Like we don't need to majorly depending on how much portal pressure and flow, all these things, because you are giving a whole liver there in the cadaver. So it's a very interesting topic. Thank you.
So one practical point I want to add is when you do a portal, like when you want to increase the future liver remnant in when a patient is undergoing liver resection, the recent technique is one is portal vein embolization. To increase the augment regeneration better, you add with the the venous embolization also of that particular segment. So this is called as liver deprivation. So the difference in the resection when you take this patient is because of the venous deprivation, there is a lot of collateral formation between the segment that is embolized to the normal future liver remnant. So when you do a liver resection, you tend to have a lot of bleeding compared to a patient who had just undergone a portal vein resection. So you need to be prepared for Pringle vascular exclusion. Like you need to prepare so that you have less bleeding during the transection compared to a patient who have a portal vein embolization. This is a difference in the practical point for patients who have undergone a venous deprivation.
Any more questions from the audience? From the alumni, anybody would like to ask? Thank you, sir, for joining us from abroad. So, on behalf of the Department of Surgery, I would like to extend a thanks for you for joining. Unfortunately, I can't give a moment on. Thank you, sir. Thank you very much. We will move on.
Right.
So we will move on to the next talk by Dr. Shrikant. So thoracic laparoscopy, esophageectomy, a video lecture. So the chairperson for this session are Fani Krishna Ravala and Vaidishwaran and Parthasarath. Please come.
Dr. Shrikant doesn't need any introduction here. He's a senior consultant at GI surgery and he works in Bangalore. He is the director of his hospital, Shastra Gastro Center, and he also works in Apollo Jainagar. He has vast experience in minimally invasive GI oncology. So he'll be talking to us on thoracoscopic esophagectomy.
Good afternoon, everyone. Thank you, Dr. Vaidi, for the intro. Thank you, Professor Vishnu, for inviting me here. It's always a pleasure to be here, and I'm happy to be here in the second alumni meet. I would be taking you through the steps of thoracolaparoscopic esophagectomy. We used to do esophagectomies transhiatal in our initial experience, and from 2006 we embarked on doing esophagectomy thoracolaparoscopically, and from 2011 onwards, I can't remember, it's always been a standard protocol to give neoadjuvant therapy and then take them up for esophagectomy. And okay, so when we our preference when we do a thoracolaparoscopic esophagectomy is to place the patients in prone position, so they have a double lumen tube. We have three ports placed in the chest, which is in the sixth, fourth, and the eighth spaces. Sixth space we have the camera. This is in the posterior axillary line. So the advantage of thoracoscopic approach in the prone position is, with the 8 pneumo, you could have a lung collapsed and a clear visualization of the posterior mediastinum. So the magnification gives you an idea of anatomy here. There are 4 steps that we plan when we do the thoracoscopic part. So the steps of the procedure are basically, we divide it into 4 phases. One is the dissection, which is anterior, in the anterior plane. And second step would be the posterior plane dissection, azygous vein ligation, and the cranial esophageal dissection, which is supracardial. So the anterior dissection, why do we do this first? Because if you dissect posteriorly, you could have bleeding from the aortic branches. You don't want it to obscure the field. This is a avascular area, so you can develop a neat plane in this area. So the mediastinal pleura is divided, and then you develop the plane and move towards the diaphragm. You have the inferior pulmonary ligament here, which you will divide. There are 4 important structures. One is inferior pulmonary ligament. So you have the inferior pulmonary vein in relation here. So one needs to be careful here. As you move up, the other structure in this plane is you could injure the membranous trachea, you could injure the azygos itself. So you have gone up to the diaphragm, and then you are moving up cranially and incising the pleura over the azygos vein. And this helps you loop the azygos vein. So that's again the posterior dissection, the pleura being divided up to the thoracic inlet. As a subclavian, the right vagus, you moved up to the inlet. Now, when you ligate the azygos vein, you always ligate it first on the away from the superior vena cava. You want it to, you want this part to collapse. Otherwise, you would have a bulged azygos vein, which might make it difficult to ligate distally. So this is the completion of the posterior dissection. You see the pericardium, the plane of dissection is in the pericardium. All the tissue is en bloc with the esophagus. You move till the mediastinal pleura on the left side. Now, azygos, before we ligate the azygos, here I'm dividing the vagus. Now, could you divide the vagus early in? We always divide it at this stage, because it holds all the periesophageal tissues. If you divide it early, you would lose this advantage. And that's the left bronchus coming into view. That's the left bronchus. While we remove all the periesophageal tissues en bloc, we do not remove the carinal lymph nodes because it can be, the field can be oozy, and so we would do only the carinal lymph node removal towards the end. Azygous vein, you have ligated on both sides. We usually use clips on either side too, and then divide. Then you go to the posterior. So you finish the anterior, this is the posterior dissection. So you made an incision, you are extending the dissection onto the left side, the left limit being the mediastinal pleura on the left side. This is an avascular plane. You could have branches coming in from the, you see, working here with a hook and a left hand a bipolar device. You could use a harmonic shears for your division, dissection and division. But I prefer using in the thoracic part monopolar hook and a bipolar as my left hand instrument. So that's the left vagus there. So you don't divide the vagus early in because it holds all the periesophageal tissues. If you divide early, you get lost in the planes. So that's the carina and the right and the left bronchus. You're taking the periesophageal tissues from the left side onto the esophagus and the cervical esophagus, which is mobilized up to the inlet, thoracic inlet. Now you see, we don't do a formal dissection of the recurrent laryngeal nerve lymph nodes. These are patients who have received neoadjuvant therapy with esophagectomy to the extent that I have shown. We always get a lymph node yield of about 12 to 15. We remove the subcarinal lymph nodes at this stage. So you could have a little oozy field when you do the subcarinal lymph node dissection. When you use a bipolar for your dissection, we don't use a harmonic in this area. There's only once we had an injury to the membranous trachea, which we had to fix during surgery. So that's a catastrophic complication. So that's the subcarinal lymph nodes, which are being dissected and removed separately. So left, right bronchus, the mobilized esophagus. You look at the field, you place a chest tube and withdraw the ports. So that completes the thoracic part of the dissection with the esophagus mobilized from the inlet to the diaphragm, diaphragmatic hiatus, en bloc with the lymph nodes around. Now the abdominal part has the following steps, which is you make a greater curve mobilization based on the right gastroepiploic vessel arcade. The patient is operated in a leg split position. We have 5 ports. You see a 6 port here, but typically it's a 5 port, like any foregut procedure. So the first step would be to enter the lesser sac. Make sure you're about a centimeter away from the gastroepiploic vessels, right gastroepiploic vessels. You need to divide the left gastroepiploic vessels before you take the short gastric vessels. This mobilization based on the gastroepiploic has to be done meticulously, and the D2 should be mobilized. We don't do a cockerization maneuver routinely. The stomach comfortably reaches if you have done an adequate division of the greater omentum. So those are the short gastrics which have been divided, and then you can see the mobilization up to the left crus. That's the left crus which is exposed at the end of your dissection. The GE junction of pad of fat, which is being released from the diaphragm. Then you go on to the right side where you divide the gastrohepatic omentum here, and that exposes the right crus of diaphragm. Extend the peritoneal incision circumferentially, anteriorly to the left. The mobilization now continues along the right crus. This is all a avascular plane. So that's the retroesophageal window being developed. And you can see you're already communicating with the mobilized esophagus in the mediastinum. So that's the mobilized esophagus. A few attachments in front, anterior, and the left crust side are being released here to completely detach the lower end of esophagus. This mobilization may be aided by placing a ribbon as you do when you do a fundoplication. We don't need to routinely place that. So that's a completely mobilized esophagus. This is a left gastric artery and the coronary vein. So that these vessels are secured at their origin. So you take the lymph nodes along the left gastric onto the specimen side. You see the left gastric, the coronary vein and the left gastric artery. So these are individually dissected. One needs to be careful about the left gastric artery divisions. There are times you will have a replaced or an accessory left hepatic artery. So you need to preserve the replaced artery if it is a replaced artery during this part of the dissection. So the coronary vein is being clipped. You had the left gastric clipped. Use a harmonic to divide the coronary vein and the left gastric artery. So that essentially completes the mobilization, and you prepare the lesser curve for stapling. So these are the variations in the left gastric. So you see here there's a left hepatic artery which is coming in from the left gastric. Sometimes you have two branches of left gastric. So you need to follow through, dissect and secure those vessels close to the stomach in such an instance, preserving the left hepatic artery. So that's the lesser curve being prepared for stapling. Now the staple line is placed after the Ryle's tube. If you passed it across, is withdrawn, and you place the staple line. Typically, you would require 3 firings of staplers to separate the stomach. And once separated, you attach the proximal staple line to the cranialmost part of the conduit of the stomach. So this is the staple line proximal after you have done your division. There you're taking a suture to the cranialmost part of the conduit. That holds it there. So at this juncture, either we make a neck incision and you can get the specimen out from the neck, and that pulls up the conduit into the neck, and you could complete the anastomosis in the neck. Alternatively, this stapling is not done. We make a mini laparotomy, which is about 8 centimeters below the Ziffy, meaning from the Ziffy 8 centimeters down, and divide the esophagus in the neck and deliver the specimen out and do the gastric conduit outside. That helps you do a pyloroplasty and also feeding jejunostomy through that small incision. I haven't shown those steps of anastomosis in the neck and the feeding jejunostomy. We always do a pyloroplasty. Thank you.
Thank you, sir, for a wonderful video.
Procedure in prone position.
Can you tell us that experience with the tracheobronchial, membranous tracheal injury, like what steps you did, how did the anesthetist manage, and how did you handle it?
The membranous trachea is usual, and particularly when you have adhesions in this area, I think one needs to keep the dissection, use a hook, pick up the tissue, be sure before division. If you're using a harmonic, make sure that prevention is what I'm saying. We don't want to end up with that situation. So use harmonic, the active blade on the, facing you. You should be able to see the active blade. So that should be the way you deal with to prevent. Now, this injury was at the carina, I would say more onto the left bronchus. So we took a 1 inch wide, 3 inches long pericardial patch. So the subcarinal region, maybe about a few 2 centimeters below, that was the base of the pericardial patch. And then you made basically used a scissors to develop that patch and flipped it backwards onto the, I took 3 sutures like you do a Graham's patch closure for DUPF. So 3 Weichel sutures. You can't directly approximate. I mean, because of the, it doesn't yield basically. So then we put a patch and tied it and used glue over that area. Now, when we did this, we had this can be cumbersome if you have the double lumen tube. Changing a tube at this stage is also difficult. So these are things we should know. If it is a single lumen tube, you could do manipulation of the tube. Should be all right. Double lumen tubes can be difficult with the patient in the prone position. So carefully we placed the sutures. We electively ventilated 24 hours, but I don't think it is required. I mean, we reviewed a lot of literature later. It's not required. So you do a patch closure, should be all right. Now, is there anything else you could use? I have not read about techniques of using stomach conduit in the mediastinum, but that requires you go back in to do that, to patch up the conduit onto the, that's done more in the neck. I haven't read about that. So here we used a pericardial patch. Intercostal patch, I think it's very difficult.
What suture?
Weichel suture. So we used a 3-0 Weichel suture, 3 interrupted sutures, flipped the pericardial patch back, tied it, and put glue there. So the patient had an uneventful recovery otherwise, this patient.
Do you ask the anesthetist to push the tube across the hole?
No, it was a double lumen tube. They deflated the cuff. There was air leak during our repair, but once we closed, we didn't have issues. We couldn't manipulate the tube, definitely in this case.
One of the views is you do not ask them to push it in because you can increase the tear on the trachea. One more thing I wanted to ask you is how do you deal with the thoracic duct? 1. 2, do you preserve the bronchial artery always? Make effort to preserve the bronchial artery.
Yes, I mean, if you see a bronchial artery, you would try to preserve the bronchial artery. As regards thoracic duct, if I see it, I clip it, but I don't routinely clip it. So if it comes during dissection, it comes, I mean, you should be able to see many times when you are dissecting. This is one more reason I say that if you are using energy source, you should be careful when you do the posterior dissection, because you could injure the thoracic duct, particularly where it curves to the right. So we would, I would avoid normally using energy source. I would clip when I see it. Otherwise, I won't. Have I gone in and done the thoracic duct clipping? In 3 patients, we have done thoracic duct clipping when the ICD output was high, running more than 500s. In the 3rd, 4th day, we went in early and clipped it.
You use ICG for that?
No, I haven't used ICG.
There are people who don't routinely ligate the esophagus. What is the advantage of ligating on problem of not ligating? Why do you ligate routinely?
I think once you finish the thoracic part, you pass, I mean, you go to the abdominal part, you do it. You don't have a vision of the thoracic part. I'm talking when we do thoracolaparoscopically. When you are doing even transhiatally, you have the pleura along. Now it will be as though it's only the esophagus hanging there. You would pass a Ryle's tube, you may come on one side of it and come on the other side of it.
Exactly, my fear also.
You may pull up the gastric conduit. You will have staple line on the conduit, which can tear against the esophagus. So I am very concerned about, I mean, why would I do it? I mean, for what reason? So when I'm doing thoracoscopic, I would ligate it. I would put a clip. And another thing is when you take the conduit up, always use a polythene, what you use for a laparoscopy, use a sheath and take the conduit inside that. Don't try to take it up directly because again, it can dislodge the clips on the esophagus. There's no way to control it. I think if such a thing happens, you'll lose the patient.
Any questions from the floor?
I think the extent to which you go from the inlet to the diaphragmatic hiatus, epiphrenic lymph nodes, yes. You take en bloc all the lymph nodes. I said posterior dissection plane, go to the pleura on the other side. Beyond this, taking formally the recurrent laryngeal, no.
Because that is the place where you are likely to injure the nerve. I just wanted to know how it can be prevented and notes can be.
I don't do. I think if somebody is doing formally, see, they think it's like this. It's a philosophy. I mean, it's what we do. Neo-adjuvant, you're given, you do en bloc subjectomy, you get adequate lymph nodes for staging purpose, which can tell you what the survival is going to be. Now you will have a better idea. But what would a lymph node clearance in left recurrent laryngeal? That's the most common site for recurrence of disease. So you might not have local recurrence, but does it translate into survival advantage? These are issues we don't have clear answers. So we don't do it as a routine.
Neck anastomosis, your technique of neck anastomosis?
Always use a linear stapler and then close the enterotomy. So do it in the posterior wall of the gastric condyle, a little away from the apex. Make a small gastrotomy. You have taken stay sutures between the esophagus and the stomach, on right and left side. Make a gastrotomy. Use a linear cutter, and we go to the depth of around 2.5 centimeters, about an inch, and you have another. The anterior closure when you do another, so 3 centimeters should be the approximate size of the anastomosis. So leaks are less, definitely. I mean, I remember those days when we used to do a hand sewn. I think leaks must be in the less than 5-6%. With this, it's less, definitely much less than that.
I forgot the techniques. One is the Oringers. The modified collapse, is that what you're talking about? One advantage is the stricture rates are almost nil with modified collapse. So with tracheal injury, one thing I noticed, I've had a couple, if I show you 2 cases. Sometimes the patient immediately.
Unfortunately.
So, unfortunately, yeah, that's what I mean. So one thing is you can't. Sometimes they're not able to ventilate the patient. In that sense, then it becomes a crisis. So in that case, you don't have a choice but to actually advance the ET2. Then you can do a relaxed repair. If not, it becomes a serious emergency.
One last question. In case you need to convert,
okay, I'll talk about the conversions. See, what kind of a conversion? I remember, I mean, this is not, I mean, I don't have the full clear data, so I shouldn't speak, but let's say I put in the scope post neo-adjuvant. Some people have a lot of adhesions. I mean, with the scope, you could just get it off. Like I mean, you could get these adhesions off patiently. You could have another instrument inserted and patiently get these adhesions off. It's possible. But there are times for other reasons. I mean, maybe patient had past tuberculosis. I don't know. In 2 patients, I had to move to, I had to do a transhiatal. So I moved to a transhiatal way, meaning I put the patient in the supine. I went here, mobilized, and then went into the mediastinum, and the rest was like in transhiatal, the neck. And so that was 2. So I would consider it as conversion from what I wanted to do. I did this is one more thing. When you do the thoracic mobilization, you have everything in view. Detach everything to the inlet to the outlet. I mean, don't leave that lower part for abdominal side clearance. I remember early in the experience once, post neo-adjuvant, I mean, this was 2011 or so, there was an inferior pulmonary vein injury, transhiatal. I had finished my esophageal mobilization. I was in the abdomen. I'm going from below. I have detached. When I did the dissection, when I went into the mediastinum, there was a strand, and I held with the ligature and divided. It was an inferior pulmonary. So I had to rehold it, and that was a conversion. Means I called the cardiac guys. I wouldn't like to have those complications now, but I mean, it's potential complication.
Last question is, your volume of esophagus decreased significantly because we find that esophageal surgery is coming down remarkably because of definitive CTRT.
I think the number of, I mean, that's a separate discussion on all areas. Like liver groups were 3-4 in Bangalore. Now there are 25 groups. So I think volume of liver resections has increased overall, but in individual groups it remains small numbers. So I would think it's similar with the esophageectomy thing, which means when I was in global hospitals, we used to do about 8 to 12 per year. So now it's about 4 to 5 per year. So that's the difference.
Supposing you do Ivor-Lewis type of esophageectomy, how do you do the anastomosis? Use the endo-J or?
Honestly, I know when I will do Ivor-Lewis.
And supposing you decided to do, what sort of anastomosis? How will you do the anastomosis?
Should be a hand-sewn. I mean, you'll have to put you make the conduit.
Why not use the endo-J step? Because recently we did one, that's why I'm asking.
No, maybe it's just the comfort level of doing it. It can be used, but I think the positioning, all that you may have to explain. It's a cumbersome thing.
You can do the
Easier
use the
to do
Orwell.
the hand-sewn for Ivor-Lewis.
No, we can use the Orwell.
You could use the Orwell.
No, we
But it can be
actually
different.
we did recently one that was a case of gist at the G junction. Following imatinib for some 3 to 6 months, we took up with the size was quite reduced. We did that gastrectomy and pulled just like that. We pulled the stomach conduit and anastomosed in the thorax by making an incision and putting endo-J stapler. Specimen was removed from the thorax using this wound management.
Orwell is still available. Huh?
Yeah, I was only afraid that it causes stenosis at
That could be a concern, but when even G junction tumors, when there's extensive lesser curve involvement, if you go with the pre-neoadjuvant margins, you won't have enough stomach to take up induces. So even then, we still do once in a while Ivor-Lewis.
Yeah.
It was an excellent session, great discussions. Thank you.
We have a memento. The chairpersons will give to Dr. Srikanth. Next, we have the lecture by Rajinikanth Pacha. Topic is acute liver failure management. The chairperson for this session is Dr. Rajesh, Dr. Muthukumar Swami, and Dr. Shaktived. Request them to come to the dais there. Dr. Shaktived, Muthukumar, and Rajesh. Yeah. Dr. Rajesh. Dr. Rajesh, you can introduce. Okay.
So, Dr. Rajinikanth is he's a senior consultant in Gleneagles Global Hospital in Chennai. He's a senior most liver transplant surgeon and know him very well for the past 10 years. Over to you.
Thank you, Rajesh. It's always a great pleasure to come and give a talk in front of professors where we learn from Professor Anandkrishnan and Professor Robin Smile, and really nostalgic to see all the colleagues and seniors and juniors. And thank you very much, Professor Vishnu Prasad, for inviting me. And this slide for new PEs I just put, but everyone knows these things we can do in JIPMER. We used to play cricket with the house officers, and I have a photo. Professor Smile used to give momentum, and Professor AK was there next to me. I didn't get that photo. Next time I will try to get that. So this my talk goes on briefly. I'll try to discuss acute liver failure as a case discussion, an introduction, and what are the etiology, and pre-transplant issues, critical care management, and indications for transplant, and briefly on types of transplant. I won't go detail, and outcomes. So this is a patient came to us, 20-year-old gentleman with common, this part of the India is suicidal intention with rat killer poison, And he's treated conservatively peripheral hospital, and then he came to global for further treatment. At the time of presentation, his labs were like this. His liver functions are grossly deranged with INR of 7, and AST/ALT is very high. So we managed supportive therapy as any acute liver failure. We start with NAC infusion and sodium chloride, and then we started plasma exchange for this gentleman. Initially, we give plasma exchange for all rat killer poisonings, and then we assess the liver whether it's improving or deteriorating over the time. And simultaneously, we try to prepare the family for the donation. So it has to be simultaneous. As soon as they present, it's better to talk to the family and keep the family aware that anytime these patients can deteriorate and needs transplant. So his liver function, as we expect, deteriorated. Then he was already fulfilling the King's College criteria for acute liver failure. So we worked up the living donor further, and these are the King's College criteria. Normally, paracetamol poisoning, non-paracetamol poisoning. We are mainly concerned with non-paracetamol poisoning. Once the INR is greater than 6.5, straight away fulfills the criteria. Otherwise, any three following categories, either INR more than 3.5 and bilirubin of more than 18, and age less than 10 and more than 40, and non-A, non-B. These three factors has to be there. So we did the transplant, and these are the graft details. We gave 714 grams of liver, right lobe, and GRWR was 0.95. So these are the technical aspects of the transplant and biliary reconstruction. So we introp details is blood loss is 1 liter, and patient being shifted to ICU. And for day one itself, we had to could extubate this patient after doing Doppler. So ward shifting day 5, and he has a smooth recovery post-op, and we discharged day 14. These are typical course of acute liver failure. These are the pre-transplant bloods, and immediately after transplant and at the time of discharge. These are you can see the remarkable improvement in INR and bilirubin. So explant pathology shows massive necrosis with the ratol poisoning, and this no way could salvage with conservative management. And this is the gross cut surface, and you can see the histology, lot of necrosis, those red areas you can see. So typical ratol poison, they come and whole liver you remove and put the right lobe. So what is ALF? So no pre-existing cirrhosis. The patient has to be normal, no liver disease, and INR has to go up, and any degree of encephalopathy, it has to be less than 3 to 6 months. These are further subdivided into jaundice to encephalopathy. This is very important. Hyperacute in 1 week. If jaundice to encephalopathy is less than 1 week, it's called hyperacute. If it is less than 1 month, it's called acute liver failure, and less than 3 months, it's called subacute liver failure. So commonest etiology in India is viral, and abroad is paracetamol poisoning. In South, a little bit different. It's a rat killer poisoning we quite often see in especially Chennai, Tamil Nadu area and Andhra. Rather than viral etiology, we see a lot of rat killer poisonings. So these are the causative factors. Viral hepatitis A, E can cause acute liver failure, and all rare infections, leptospirosis, dengue, all those can cause, and acute Wilson's, acute Budd-Chiari, fatty liver pregnancy, then non-A, non-B, and some of the drugs, ATT, phenytoin, all antifungals can cause. Toxins, as we mentioned, rat killer poisoning most common here. And abroad, I've seen one case with ecstasy poisoning in London. Patient had a weekend, a big party, rave party, and patient has come, young person, came with acute liver failure within no time. And there we have a privilege that we can do cadaver transplant. Immediately alerted, within 24 hours, new liver comes, and he walks with new liver. So pathophysiology is all these functions, metabolic functions, and biliary drainage, detoxification, everything will be deranged in acute liver failure so suddenly. So basically, liver shuts off, and the natural course shows like this. Once the acute liver injury starts, they can either present with encephalopathy, or they gradually improve without encephalopathy by supporting measures. So once encephalopathy starts, you have to prime the family. He will definitely need transplant. So before he completely lost the game, then we must prevent by doing liver transplant. And once you do, it will be clinical recovery will be there. So prognostic criteria depends on etiology, age of the patient, and the how severely it will progress. These are the thing. And King's College criteria is still valid and relevant. And what are the goals of management is initial intensive care management is very, very important in these patients. And during the management, we have to see who is not improving and no regeneration. Normally, once acute insult comes, liver try to regenerate. If no regeneration is there, patient will deteriorate. You have to immediately identify and start work for transplant. So see, critical care management mainly, it's a rapidly progress into brain injury, shock, all various parameters. So our role in the management is to assist spontaneous recovery. Some patients can recover with acute liver failure, and also to stabilize for transplant. So cause specific interventions you have to do, and organ support you have to do, and prevent any neurological complications, and also CRRT, plasma exchange we have to see. So cause treatment is if paracetamol poisoning in West, they immediately start NA-style cysteine, and viral etiology, hepatitis B, you start entecavir, tenofovir, or ribavirin for hepatitis C, autoimmune steroids, but carry anticoagulation and hepatic venous stenting you can grow. Wilson's, definitely liver transplant is needed. So these N-acetyl cysteine dose, and commonly these patients will go into circulatory shock. So you have to start noradrenaline and vasopressin, and also see for septic screen all the blood cultures you have to see. Start broad spectrum antibiotic and antifungal, and look for the pancreatitis also. Some people go into, especially rat killer poisoning, they go into pancreatitis. And acute lung injury can happen, which is very, very catastrophic. Capillary leak and ARDS picture, some patients will get very severe patients. These are very difficult to rescue these people. And obviously coagulopathy is another important factor. Suppose if you're giving for any central lines, or if you're putting for dialysis, you need catheters, big lines you have to put, so you can treat the coagulate by FFP or cryo, and then start with the treatment. So TEG monitoring and ROTEM monitoring is very, very important. It's a very dynamic process. The acute liver failure quickly changes into deterioration level. So TEG and ROTEM are hourly or 2 hourly you have to monitor. And then infections, always screen and close surveillance needs. So neurological management, the patient, when he comes, immediately you have to assess which grade of encephalopathy. Then you have to monitor him every 2 hourly, how he is developing. So these are the grades, various grade 1 euphoria, and grade 4 is a coma. Then immediately you'll need intubation and treatment for that. So high risk for intracranial hypertension is coma, young people, hemodynamic instability, vasopressors, low sodium levels, and ammonia also very high. These can cause increased intracranial hypertension and renal failure. So how to monitor neurologically? So commonly bedside, you see the pupils, they're reacting, or the size of the pupil and reacting. And then blood parameters like ammonia, sodium, all that you have to see. And ABG is very important. And how to monitor this thing is sometimes we do transcranial Doppler. You measure the middle cerebral artery velocities and flow form, and also optic nerve diameter also you can see. If it is 4.5 to 5.5, the intracranial hypertension more than ICP rise should be more than 20 millimeters of mercury. So this is a very indirect evidence of rise of ICP. So with all this, and the bolts very rarely using nowadays, and these are old technique. We put the bolt and monitor the pressures. And how to manage ICP is you try to be common goals is the cerebral perfusion pressure should be less than 20, map of 60 to 70 has to be there. And you have to, if patient is grade 1 or grade 2 encephalopathy, immediately you have to intubate and ventilate, and propofol sedation, head and 20 degrees, 30 degrees, so that the pressure will be less. And then other parameters, how to reduce ammonia production, and also increase ammonia excretion. So you have to start immediately CRRT, and then you have to counsel the family for transplant. So this is liver is a very important organ. All the waste products, ammonia products, it converts to urea. Its urea cycle is mainly in the liver and then excretes via kidney. Everything is stopped, and ammonia levels will be raised in the blood once acute liver failure starts. It can have a direct impact in brain first. So these are the measures. What I mentioned is broad spectrum antibiotics and ABG monitoring, oxygenation, vasopressors, and electrolyte sodium levels. Very, very important, these things. And a little bit about extracorporeal measurement. CRRT is the main stay for the treatment of conservative measurement in acute liver failure. Commonly, whenever the patient has hyperammonemia, lactic acidosis, and if renal shutdown, severe acidosis, then we have to start CRRT. And dialysis is there, but CRRT is very useful because the patient the hemodynamic parameters will be stable in CRRT. So it clears urea and ammonia, definite role in ALF. So it reduces, it very useful in reducing the ICP pressures also, CRRT. So it can treat lactic acidosis, metabolic acidosis, and hyperammonemia, very useful, this one. And all the electrolyte abnormalities also we can correct. So obviously we can control CRRT, what are the things we can give and how much fluid we can remove, all that we can control through this mission. So this is less hemodynamic fluctuations, and it prevents the cellular edema, removal of ammonia and middle molecules. This is a very useful modality of treatment. And plasma exchange also very important. All these poison toxins it can remove, and also bilirubin levels also it will remove with the plasma exchange. So these measures we see. So when you see the patient is deteriorating or patient is not for transplant, is when neurologically pupils are dilated and fixed, that means his brainstem is coning and is not fit for transplant. Similarly, severe sepsis and respiratory problem, if his FiO2 is too high, and even though you do transplant, the lungs will not improve, plus higher age. And if he develops any necrotizing pancreatitis, you have to be very careful. Post-op, they will not recover well. So these are the contraindications. Active sepsis, which is not treatable, and brainstem herniation, and elderly age medically. Relative is active substance use, alcohol use is the relative contraindication. So over the course of years, treatment for ALF has drastically improved. If you see before 1985 and 85 to 95, 95 to 2005, the survival rate has dramatically increased. Mainly, the improvement in the treatment is ICU care has significantly improved, and also awareness about the transplant and transplant outcomes also has improved. So once you decide patient needs transplant, So what type of transplant you have to do? You can opt for deceased transplant, cadaver transplant, and living related transplant also. So in India, cadaver transplant is very difficult because once you raise alert, getting the organ is difficult in India. So abroad, within 24 hours, you get the organ once the raise. It's a national alert, like UK and USA, you get organ immediately. So in India, the best is living related liver transplant. The family is aware and they are going to give the half liver, you tell them, and less waiting time will be there. Within 2 to 3 days, you can work up the donor and immediately you transplant. So living related advantage is you can select the donor. Obviously, the donor we will select between 18 to 45 years, and the liver will be very good quality. The regeneration capacity will be very good. So these are the advantage for the LDLT. DDLT waiting time in India is too long, and sometimes you get fatty livers. In that case, you cannot transplant. So, and logistics for DDLT is a lot. So these are the various types of transplant. The survival rate, obviously living related transplant has a higher survival. And a little bit about the auxiliary liver transplantation. This is whenever a patient with acute liver failure, you always have to consider whether he is fit for auxiliary liver transplantation. Auxiliary liver transplantation is used when we have to use very carefully. You have to select the recipients because already patients are very sick and there is no chance for error in these patients. So auxiliary transplants acts as a bridge to native liver regeneration. Sometimes these livers are all acutely insult, still they have a capacity to regeneration. So you resect half of the liver and give the liver, half liver to the patient. And then you monitor closely over next few months, and slowly the advantage for this is you can withdraw the immunosuppression if the native liver regenerates. So the advantage, main advantage is long-term immunosuppression. You can avoid this one. So we have done 6 transplants auxiliary last 3-4 years, and this is one important case. A 4-year-old boy previously well, and he had a viral hepatitis, and immediately we worked up the donor. So he had a worsening LFTs and coagulopathy, encephalopathy. Admitted 11th February, 14th we transplanted. The donor is the mother. We did auxiliary because when we open the liver abdomen, we can see some of the regenerative nodules in the liver. So we resected the left lobe and we gave a left lateral segment to the baby. And we discharged on day 8, I think. So slowly post-op, we monitor this patient. These are the parameters. Obviously with auxiliary also, the new liver will work immediately and the old liver will take over once the acute insult is fades away. That is in 3 to 4 months down the line. So you have to, there are many papers shows auxiliary is very beneficial for certain number of cases like metabolic liver disease cases and acute liver failure with stable patients. This is very useful technique so that they can be avoid for long-term immunosuppression. So they have to be regenerative capacity should be there. We have to give this auxiliary for young patients only and stable patients. And patient clinical condition has to cooperate because it's a very technically demanding procedure. So it will take 10 to 15 hours. So patient has to be stable, less inotropes, and his ICP, the encephalopathy and intracranial pressure has to cooperate. So all these things you have to keep in mind. So, and whatever the graft you are giving in auxiliary, it has to be perfect. And for adults, you give right lobe, and for children, auxiliary, you give left lateral and left graft. So technically, it's challenging. This is what I want to mention, but we can overcome by experience only. This, if you don't have experience, better not to do auxiliary. only do for straightforward living related liver transplant or cadaver transplant if available. So as mentioned, immediately post-operative course is monitoring same like others, and follow-up and withdrawal of immunosuppression has to be based on the CT scan and HIDA scan. So both has to be complementary. Each one has to see whether we can see the growth of the native liver in CT as well as the HIDA scan. So after 6 months, you slowly withdraw the immunosuppression so that whatever the transplanted liver will get atrophied and his native liver will take over. This is the principle here. So auxiliary transplant should be considered for all ALFs if they are stable and less than 40 years. And withdrawal of immunosuppression is a very bonus for these patients once acute liver failure settles. So in our experience, we have done past 4 years, 40 ALFs and 34 adults, 6 pediatric. Most common etiology, 22 is ratal poisoning. And commonly we give plasmax and CRRT combination. We have lost 2 patients post-op and we did 6 auxiliary transplants during this time. And to conclude, ladies and gentlemen, ALF is a multi-organ inflammatory disorder. Organ support till transplant, we have to monitor whether patient is recovering or he needs transplant. So neuroprotective measures is very important. CRRT and plasmaxine are the bridge for transplant, and patient deteriorates immediately. Early transplant is very much indicated, and good survival with early transplant. So it's all based on teamwork. Liver transplant is always teamwork, otherwise success is less. Thank you for your attention.
Excellent talk as usual, Dr. Rajini, and thank you for sharing all your experience. It's a very vast experience. 40 ALF transplanted is a big number. In a nutshell, actually, acute liver injury is how we started, and when in 80 to 90% of hepatocytes are gone, when the magnitude of the injury is more, it's called as acute liver failure. The most common cause of death in an acute liver failure is brain edema. So that's where intracranial hypertension management precedes more than your liver when it is more than 80 to 90%. And then you take the time to give the liver, to replace the liver, because there is no other, no dialysis technique like there for kidney. You don't have anything like there approved till now for liver. So you try to replace the liver and get them out of the situation.
Is there any questions from the floor? Just a brief question, Rajni. How do you differentiate between indication for ALF transplant in adult and pediatrics? Do you use the same criteria, or you?
In pediatrics, slightly different. Adults, as is King's College criteria is still very much valid. Pediatrics, the moment patient goes to encephalopathy, that is the indication for he'll need a transplant. Even though INR is there, you just have to closely monitor, but encephalopathy give more importance in pediatrics.
You are not aware of any specific criteria for pediatrics?
No, pediatrics, INR and encephalopathy.
Encephalopathy is more important. Thank you.
I just want to know what is your distribution process in subacute liver failure? I mean, patients who come beyond 4 weeks, neither here nor there, some of them may improve, some of them may worsen. So do you have any objective way in your center? How do you decide which ones you work up for transplant, which one you wait?
No, subacute liver failure is always a challenging scenario, yes. Basically. You have to closely monitor them. If INR and other parameters are stable, you can wait and watch. But you have to tell them anytime, you better work up for a donor if they have one, LDLT. So you quickly tell them anytime if they deteriorate, they'll need a transplant. So for us, no clear-cut scores or guidance, but clinically we will take it.
Because improvement happens very, very gradually. Deterioration happens suddenly.
Suddenly.
Anyone in subacute, how are you making the decision?
The difference is acute and hyperacute. The insult is very big. So the acuteness of the insult and the magnitude is very big, so they deteriorate faster. But in a subacute, it is not the insult. The insult may be mild to moderate, but the regenerative potential of the liver is less. Usually, subacute happens in older age group where the liver doesn't have a big potential to regenerate or cope up with the stress. So it's a mild to moderate injury along with the less regenerative potential combination that pushes the patient more into subacute. So this is the common cohort of patients that go into that. So these patients, they don't go into an encephalopathy because the liver injury is not that bad. So they don't hit your brain as frequent as your acute and hyperacute. They drag on. They move to more than 4 weeks. There are regenerative nodules in the liver to say that they've tried and then they form ascites. They behave more like a chronic. When you do a CT, liver is a bit shrunken and splenomegaly also there. It takes some time. But the most important thing about subacute is when they drag on and they have a sepsis, they go into encephalopathy. So the hitting point of going to encephalopathy is sepsis in subacute compared to actual direct liver injury in acute and hyperacute. So the prognosis of transplanting this subacute group, per se, they are older age group, they are very poor. So, but there is no other option other than transplantation. So this is a group where if you for a acute liver failure, you do a transplant at the right time, you have 70 to 80% survival. Whereas in a subacute, you have only around 50 to 60, I would say. So this is a very difficult cohort of patients to deal with, and then to get a good result in them is very unlikely.
Yeah, I agree with Rajesh, but these patients needs close monitoring. I think broad spectrum antibiotic starting, and they have to be very close. Means you can't discharge them sometimes, but they have to closely live near the hospital, and you have to see them every often, and anytime they can deteriorate. So very challenging subacutes actually. Sendil, you have any thoughts?
Thanks for nice talk. A couple of quick comments in interest of time. One is about the pediatric criteria. Somebody asked. There's no definite criteria, Muthu. But pediatric age group is one where you don't need encephalopathy to define ALF. Whereas adults, you need encephalopathy. We can't define ALF without including adults. In pediatric group, you don't need ALF. You just need to go by NR. That's one thing. Secondly, I agree with what Rajesh was saying about subacute. Subacute, once you land in the subacute situation, you almost always need transplant. So they'll never improve. And then it's just like ACLF. It's like in a way of ACLF. So that's where the decision comes. Thanks.
So one more question.
Thank you.
Usually when you start the medical treatment, the plasmapheresis, and how do you exactly assess that the liver is regenerating, whether it's only based on the CT based, the volume of the liver, whether the liver is collapsing or the clinical parameters? And because when do you actually decide, how do you actually decide if the patient doesn't become too sick for transplant?
Yeah, that's
the timing is more important.
Timing is very important. Based on everything, basically, clinically you have to see, and lab parameters are important. And as I mentioned, especially these adults, you have to monitor neuro, like every so often encephalopathy, whether they're how they are behaving, clinical questionnaire, and all these things you have to see. Plasma exchange for acute liver failure, routinely we start with plasma exchange, especially these rattle poisoning. So 3 to 5 cycles we tend to give. And if the improvement shows with INR, if the INR is recovering and the liver enzymes are getting better, then you can wait. If they are not deteriorating, especially day 4, 5, from there to day 7, if they are not not improving, you have to be very careful. They'll quickly, this rat killer poisoning, they quickly deteriorate day 5 to 7 time. So if they're improving, yes, you will know. After 3 plasma exchange, all bloods are fine. And if not improving, you have to prepare them.
Because sometimes if the imaging doesn't show significant volume loss, we'll just see whether we'll give time for the liver to continue the medical management.
Imaging is the secondary. Only clinical and biochemical are the pivotal, and neurological monitoring. Image comes late. It's not very. Thank you.
Thank you, Rajani. If there are no questions, we'll move on. Thank you.
Thank you.
Oh, okay.
We have Professor Lata, who is actually the president of JIPMER Alumni Association. On behalf of Surgery Alumni, I extend a warm welcome to her. So next we have a video lecture by interesting video by Dr. Rajesh. 2 videos he will be finishing quickly. So the chairperson for this Dr. Muthukumar Shaktivel and Partha Sarathi.
Let me, at the outset, I would like to thank Dr. Vishnu Prasad for this invitation to present in front of my mentors, seniors and juniors. I'm very privileged to be here. So to quickly go to the topic, the one is a complex general, like HPB surgical issue, like post-cholecystectomy biliary strictures. These are one of the very difficult, especially when they're high, to deal with, because they are patients who drag on for a long time, and unless until you sort them out in the first attempt, it is very difficult to, they have a very difficult quality of life. So this principle is based, this surgical technique is based on the principle of the location, anatomical location of the bile duct above the hepatic artery and the portal vein. So anteriorly, when you approach, the first structure you hit is the bile duct. So the whole technique is based on this principle. So let me run this video. So this is a patient who had a laparoscopic cholecystectomy, the bile duct injury high up. You can see that it has even separated the confluence or primary confluence. This is an intraoperative picture where you feel that the stricture is high up. So we like your gallbladder CA resection. This is a resection similar to that, where like you take the, in order to expose the primary biliary confluence, and the secondary biliary confluence, you take the liver out of that, so that you can deal with your intra hepatic strictures, as well as for the ease of anastomosis. So you see how high is the stricture. So this is a left side. So you can open it comfortably with all your anterior space easily, like without any difficulty. Like you can go in as much as possible to get the biliary decompression done, even if there is a high separation as even multiple ducts in the anastomosis. So here you have the left duct open. The most important thing is here, always because of the bile stasis, there are sludge formed beyond that. Unless until you have a good biliary decompression and then take these stones off, this will come again and again and can be a cause for recurrent strictures. So you have to have the strictures open wide here. So the left side, now it's the right side being open, and you extend it as much as beyond the stricture, so that you have a wider, like to the dilated part of the duct, to have a complete decompression. So this, even though it's a simple technique, it requires, it's a very complex problem to deal with. And when you do this technique, it becomes very easy in decompressing all the segment of the liver, and they have a good post-op. This is a final picture. So this is the first one which I want to say. Second, liver transplantation in India has gone a big way. Dr. Sonal is not here. Actually, it is now almost like 3,000, almost 4,000 per year being done in India. And India stands third in the world. The liver transplant centers are increasing every year. To give you a gist of how much minimally invasive donor hepatectomy, last year, last alumni meet, the discussion happened whether minimally invasive and donor hepatectomy is. So now the data has come that 1,798 minimally invasive donor hepatectomies are done. And last year, it's almost 800 minimally invasive donor hepatectomy done. And it's not to say that, it's just to show the feasibility and how things are moving across in minimally invasive. This is a transplant being robotic implantation done with robotic platform. So things have gone more and more. This is done with, even though the abdomen, in this case, the abdomen is kept open with the midline incision, but the whole implantation is done using the robotic platform. So just to show you how the maneuverability, the ease of doing the stable camera vision and the handling of the sutures. So this is just to tell that robotic platform compared to laparoscope has definite advantage in the vision, camera vision, the ease of suturing, the comfort, even if a bleeding happens, especially in a HPV case where the worry is about a big bleed, the handling those bleeds and moving on and completing it minimally invasive is a definite possibility. So here, once the hepatic vein anastomosis is done, the portal vein anastomosis is started. So the top end and the bottom end, you have a corner suture to keep things under vision. So there are different instruments in robotic platform. You choose the instruments based on what the needle holder used for a 3O sutures and the 5O. So it's a continuous suture. The biggest advantage we felt is the stable vision and the endorus movement. So normally implantation, that is doing a hepatic vein and the portal vein anastomosis in a open living donor liver transplantation takes about 40 to 45 minutes. In this case, it took about 60 minutes. So this is a post reperfusion. We went ahead doing it without opening the abdomen as well, implantation. So this is before doing this arterial anastomosis. These with the robotic instruments, we train with cadaveric vessels, artery, and then we get used to the technique of this anastomosis is done by Professor Ella. So the technique of how to handle this is ATO being used. So that helped in moving to the to perform this anastomosis. Another thing, age is not a limit, and robotic platform is an easy thing compared to laparoscope. The learning curve is very small. In fact, it is better to use your open surgical techniques to do the surgery compared to a laparoscopic. I'm not against laparoscopy, but this is our experience with robotic. It's definitely doable, and age is not a limiting factor. If time is a problem, I'm happy to. Thank you very much. Okay. Hepatic vein, yes, no growth factor. In fact, first implantation we did only interrupted, and we could do interrupted with no prolonged time. So.
Any more questions? Excellent video, Rajesh, as usual. Thank you.
There was a video. So there are instruments supplied by the Da Vinci group itself for non-human, non-human use. So the instruments, we use the finite instruments for So we get the fixed and shut it and go to that. You do it multiple times so that you get used to that before trying. Yeah.
When you keep the abdomen open and implant, do you have lesser light?
No, actually you see, it's a very good video because of better light.
You have extra light source, or it's only the camera light?
When the redness of the field is more, the darkness goes dark. It is more dark. So you try to get the blood away, suck it out as much as possible, wash it and suck it. To get the redness, the blood thing is less in the field, to have better vision. That's what we did.
And you said later you also did with the abdomen closed, right?
Yeah.
Was there an advantage of closing the abdomen? Because the abdomen is going to be open only.
Trying to find the feasibility of this minimally invasive in living donor liver
Because once you do an explant in the recipient, the abdomen has to be open only, no? The recipient nephrectomy is done robotically. The recipient nephrectomy also. Oh.
In fact, in a living donor recipient doing it robotically much easier. It can be done. So the feasibility is proven everywhere. How you implant? How you get the new organ in and then maintain the temperature? Try to do the reperfusion within the warmish metamyloid and then do the implantation. Is now the thing on. 16 is very good. 16 is there. You have to choose it. One single right hepatic vein and a photo vein. That is. Yeah, there's no supporting. No, it is good. The problem would be talking about the other ones, the versus the they're all individual. Without stabilization, will be able to work. The problem is like one. In fact, first, really, there's a lot of modular robotic lab. So you won't know the concept of port is not there. Robotic concept, you don't have ports. But in the ALUMNI, it's a central beam above with stabilizing all of them. They come with modular comes involved.
Yeah, even SSI is in 4 pillars.
Yeah, other platforms. I think the arms will be stable enough to work individually. Boom is just for orientation of the robotic arms. It doesn't give much support to the movement.
This is just to show that things are moving, and I think robotic will like use of stable vision and endurance. I'm not saying robotic. Anything which have a stable vision and endurance, they will have a big advantage. If you know all this snapping, and those like doing in the next with the practice. Only if you done with the 8 totally multiple steps like this overall. It's like multiple, not like till now nothing completed fully. So
Do you select grafts only with a single vein artery or with even with multiple veins also? You single vein because of the time.
no, you can't compromise the safety of this. In case, in first few cases, we in fact open and then put suture in the creative information. In case something happens, you cut it off. You cannot compromise. That is because the benefit out of this whole thing is still not so you can't protect this. And you will obviously take the less risk, less situation. So the result has to be absolute. Yeah, there is something. You have a further plan, so you can't take let's say child-age heroes because they don't have massive collateral. You need to have something like the patient who have a partial thrombus, who have a well-developed collateral, and then you have a because sometimes very few child-age heroes. You put a bowel comes into the island bowel. So you have this selective patient. What is the first advantage of robotic aspect is don't, and then you have so we have let you know that the things are like next year the Vinci exercise. Next year there is a the Vinci 5 version which is quite high. So if you are planning to invest, better wait and invest. 40 crores. Yeah, but still it has gone.
Thank you, Rajesh. Please take the moment.
So after this, we will have a quick short tea break and then reassemble for Dr. Senthil's talk. I request the online alumni to stay. So please join for tea outside.
In 200 meters, make a U-turn. Make a U-turn. In 400 meters.
No, everyone, but still you're saying when you walk out. Last time.
You went with fellowship. How many years? 2 years.
No, I stayed 6 years.
Big building there.
You're not
Yeah, nice. Beautiful. Big building.
कवर 5 लगा दो उसके बाद तक लगा दो थोड़ा यहाँ प्लग लगा दो इसको।
Take the next left to stay on Tara Road. In 800 meters, turn right onto Lincoln Road.
रास्ता बता रहे हैं।
2 minutes.
Turn right onto Lincoln Road. In 600 meters, turn left onto North Avenue.
कहीं लगाई ना? हाँ? नहीं ये यहाँ कहीं लेफ्ट करने को बोल रहा है, लेफ्ट जाती है।
We start.
ये कनेक्शन निकाल तो बनेगा सही। हाँ, मतलब लगा के फिर आप लगा दो।
What start means?
आ जाएगा, आप वापस ऑन करके शुरू से लगा।
After this, after Sentils, Srinath and Ravindra. Ravindra Kiwi. Sir.
Ravindra also.
Yes. Yeah, you are Rajesh left, Muthu Kumar, Shaktivel and Rajinikanth left. Shaktivel is there. Shaktivel and Muthu.
हाँ बोलो, क्या हाल है भाभी जी? हाँ बोलिए, क्या हाल है? हेलो, सुन रहे हैं आपको? वो सुन रहे हैं क्या? हेलो, हेलो।
Good evening. I invite Dr. Senthil to take the stage. Dr. Senthil is my senior surgeon in liver and liver transplantation. He did his training in UK and returned to India to set up his own program. Currently, he's heading the unit of liver surgery and transplantation in Continental Hospital, Hyderabad. He'll be talking on liver transplantation for advanced HCC.
Vishnu for the invite. Over the next few minutes, I'll try and share some ideas on liver transplant for advanced HCC. Okay. So. This thing not moving. Sorry, it's not moving. Slides are not moving. Slides are frozen. Okay. Take this thing out. Slide sharing on top. It's going to come on top. The green thing will come. Now go maybe go somewhere. Yeah, that's okay. So okay. Thank you. So I'll start by thanking my mentors, Prof. Andakrishnan here, Professor Smiles, Dr. Jagdish, Dr. Sharat Chandra, Dr. Vikram Kate, and Dr. Kadambari, and many more. I mean, and I truly owe to what I am now to my professors here, and coming to JIPMER every time is almost a spiritual experience. You know? Thank you, sir. So over the next few minutes, these are the areas which we'll be covering. I think. Thanks. So we look into the rationale of liver transplant and advanced SCC. And then we'll look at some of the criteria which we use for SCC. And then we'll look at some of the more difficult tumors, like ones with portal vein thrombus, and shortly cover some of the outcomes also, very briefly. Not moving. Sorry about this. So HCC is slightly different from most other cancers, and one important point is 90% of times it occurs in cirrhotic livers. So we have two diseases which have a different independent natural history, which you have to take into consideration before you can formulate a proper appropriate plan for that particular patient. And often the severity of liver disease influences what your outcomes are going to be, not necessarily the advanced HCC itself. And it's a field effect. Cirrhosis being a field effect, you have tumors which come back in other parts of the liver, even if you have a good R0 resection. If we have a TNM classification in HCC, but we don't use it, what we use commonly is a Barcelona clinic cancer system and a Hong Kong system. There are about 10 more. These are more commonly used. The reason is that they have integrated not only the tumor-specific characteristics, but also treatment options, and it's a form of a staging integrated into a treatment algorithm. That's what's important about this. And this is very widely followed. It has its own shortcomings, but at least it gives a framework where you can work on. And the other classification is the Hong Kong classification, which is a bit more granular, especially the locally advanced part on the table below is very well thought out, and that's what we practice. HCC has a spectrum of options available for. You have curative options, which are liver resection and transplant. Only two curative options, except in very small tumors where ablation can come close. This is a very important concept, and the rest of them all are palliative in the sense they can control disease but hardly ever cure disease. So we have local regional options, we have systemic options. Systemic options are coming up in a big way in the near future, and they're going to dominate the world of HCC in the next few decades. Coming to liver transplant itself, this is why we transplant for HCC. Although it's a cancer, by doing a transplant, we remove the whole liver. So it's the most radical of all treatments available. It removes the field, and without a question, it's the best, gives the best oncological outcomes, as well as functional outcomes if successful. But you have to select your patients carefully. And if you do so, then you have a recurrence rate in the range of about 10 to 15% over a 10-year period. This compares with about 50% recurrence rates if you resect only. And resection you can only do in about less than about 20% of patients who are child A and some selected child B patients. So this is an important comparison you need to be aware of. Tom Starzl started the initial transplant in 1967-68. Among his earliest series, he had patients with advanced liver cancer, which they didn't have any other treatment for. That's why they embarked on liver transplant. And not surprisingly, it all failed because they were too advanced. So they didn't have any proper way of selecting patients at the time. So a few others tried after that. Now, the next 20 years or so, the results were very poor. That the Department of Health in the US banned transplant for HCC. That's what we were as of 1989. Then we had people like Henry Bismuth, which I think Muthu has done a lot of work with, has worked about 6 years with him. These were the pioneers. And then Mazzafaro in Italy, they really changed the field. They published results with very good results of carefully selected patients. And that's and about 75% survival rate 5 years in very carefully selected patients. So that's why we are here talking about transplant as an option. And what are the principles of going for transplant in HCC? First of all, you should compare better when compared to other available modalities with a low recurrence rate and longer survival. And then you have to also maximize the use of a public resource when it comes to a DDLT situation, so disease donor situation. Morphology, which is size and number, were the initial criteria, and most of the current systems also use in some form morphology as a surrogate for biology, but it's not very accurate. Most of them have 5 centimeter ceiling as a criterion, although some of them do exceed that. And size, of course, is more important than number itself prognostically. But more and more people are moving into biological markers, like simple markers like AFP, PIVCA2, and then PET avidity, FDG avidity on PET, macrovascular invasion based on radiomics. And some of the centers also do a biopsy to make sure it's not a grade 3 poorly differentiated tumor. So these are other ways of selecting. Biology clearly trumps morphology. A slight difference between how we approach deceased donor and living donor, and as far as HCC is concerned. In DDLT, the concept is it's a public resource, so you have to ration it so that the maximum benefit is given to the community. So we have very strict criteria like Milan criteria and UCSF, which we will briefly cover later. And expansion is considered a graft wastage. And not only that, it limits the access of other patients who are more eligible and maybe who live longer than patients with advanced cancer. So that's a very important concept in DDLT. That's why most of the time we have very strict rules on who can get DDLT. In LDLT, it's different. It's considered a private gift, and as long as you can ensure reasonable safety of the donor, you can expand the criteria as long as the family accepts a higher recurrence rate. You may not achieve an excellent 5 years or 75%, but it's much better than somebody dying in 6 months. So that's a very important concept in HCC. There are about 30 different variations in the selection criteria, which we'll not go into details about, but it doesn't really matter that much as long as you know what we follow. So the most popular are Milan criteria, which Mazzafaro published in Italy earlier. Single lesion less than 5 centimeter and up to 3 or less than 3 centimeters. Obviously, no macrovascular invasion and no extrahepatic spread. And then we have the University of California, San Francisco criteria, UCSF criteria, which is slightly more expanded than the Milan, with a higher limit on the size. This is what we follow in India, and this is where even the NOTO, the apex organization, which deals with allocation of organs, is what the limit they have set. UCSF is what we follow. Anybody who's listed for liver transplant for liver cancer, HCC, should fall within this criterion, UCSF. So beyond that, you cannot list them for cadaveric organ. And if you go to the most liberal of criteria, you have something called extended Toronto. These people, they have taken any size, any number, no extrahepatic mets and no macrovascular invasion, but they always do a biopsy to make sure it's not a poorly differentiated tumor. So this is the most liberal of all criteria, and they have demonstrated reasonably good results as well. So what do we call as advanced HCC? There's no universally agreed definition, but putting together all the available different guidelines, the society consensus, this is what you arrive at. This is what we follow. So anything beyond UCSF in India, based on size and number alone, if the patient has portal vein tumor thrombosis or any 2 or more of the 3 criteria, the lesion more than 5, number more than 3, and vascular invasion intrahepatic, or if it's a diffuse infiltrative HCC without metastasis. So this is what we call as advanced HCC. What do we do with them if we see a patient with advanced HCC? 2 approaches. One is you can offer them LDLT. If the family is agreeable, you can expand the criterion with some checks, mostly biological assessment of the tumor. It can be a combination of tumor markers, PET avidity, biopsy, and nowadays there are other radiomic features also which predict microvascular invasion to some extent of accuracy. So in LDLT you have the liberty of expanding criteria, but in DDLT you have no other option but to downstage them. So we'll come to what it means. And what do you do if you expand criteria? How are the results? So sorry about the busy slide. The important thing here is if you have UCSF criteria, Overall survival is 80% there. These are all extended beyond, most of them beyond UCSF, and you see 73%, 82%, and so on. So it's comparable as long as you pay some attention to biology. You can expand beyond, and this is in the LDLT situation. What about downstaging? Again, downstaging applied to people who are outside of criteria, but you apply different therapies to bring them within criteria so that they have transplant access, less recurrence, and hopefully prolonged survival as well. The various downstaging strategies, you can divide them into local, regional, and systemic therapies. As far as the advanced disease is concerned, ablation is often not applicable because the tumors are quite big or multiple. So when it's possible, you can apply microwave ablation. That's the most commonly used. But most often we use a combination of transarterial chemoembolization or transarterial radioembolization, TACE and TARE respectively, and radiotherapy. Often is this BRT. Proton is very limited availability. And so this combination of, often we combine these two in various sequences, and we combine that with systemic therapy also. Often it's lenvatinib, multi-kinase or nowadays immune checkpoint inhibitors, this combination, atezo and bevacizumab combination. So a lot of publications are coming out now as we speak, and in the last few years as well, which support very good downstaging with a combination approach. And there's very good evidence in the liver resection scenario. So 2 examples I've given of systematic reviews. The gist of that is in the setting of resection, this is not in transplant, just I want to remind you, setting of resection, if you just use only monotherapy, for example, TACE or TARE only, or only use systemic therapy, the chance of conversion is only about 10% for advanced tumors coming down to a size where you can safely resect them. Whereas if you apply triple therapy, which is a TACE or TARE plus SBRT plus systemic therapy, then it jumps to about 4 times that. That's a very important piece of statistics to remember. So combination is better, and you can't the beyond uses of criteria is a very heterogeneous group. You can't transplant all of them or hope to downstage all of them. So the American people have come up with this criteria as an entry criteria. It is not a transplant criteria. It's an entry criteria even for downstaging. So they will only downstage if the patient fits into this group. So which is almost similar to the BCLC expanded criteria. And there is evidence that if you stick to this UNOS downstaging criterion, you have very good results. So this particular publication has 25 studies of 4,000 patients, very heterogeneous strategies for downstaging. But what's important is if you start off with a UNOS criteria for downstaging, you have 83% success of downstaging, 48% chance of transplant, and very low recurrence rate compared to very poor figures on that side, which are beyond the UNOS criteria. And survival for UNOS, within UNOS criteria, you have very good 75% 5-year survival, which is excellent. So the message is in advanced HCC, downstaging is the best option you have. So better to follow the UNOS entry criteria, which gives the best results, and combination therapy for downstaging is the best. What about HCC with portal vein tumors? This is a very important and different group of patients, because even the most liberal of criteria do not include patients with portal vein thrombus. Even the Toronto criteria I told about, they exclude patients with invasion, portal vein invasion. But there are people who have gone beyond that also and tried to show what is possible. So there's a different group of patients. It is advanced disease, and at presentation you will have about 40 patients who have portal vein thrombus. They are excluded from transplants because of very high recurrence rates. But if you leave them alone like that, the median survival is about 6 to 12 months from diagnosis, and it can range from 2.7 to 18 months. And this is a very landmark publication which came out from China, and they showed that in their group of patients, if you transplant them, all comers, you have a 2-year survival of 24%. It's much better than medical treatment, which is 4%. So this is where the thing started, and that's the publication there. And so they reset the bar for transplant here. So you can classify it into 4 different groups. Basically, VP1 is segmental portal vein, VP2 is sectoral portal vein, VP3 is lobar portal vein, left or right, and VP4 is main portal vein, or it extends into both lobar veins. So very simple classification. It's got importance in selecting patients. Again, downstaging is possible, but here slightly different. You use both TACE and TARE as well as SBRT for optimal downstaging. Plus, you can add systemic therapy. For PV tumor thrombus, it's very, very radiation sensitive as compared to the main tumor. This is a huge difference in concept itself. So for effective downstaging, you can use radiation therapy for the portal vein, and you can use other therapies for the main tumor. This summarizes the response rate, 78% complete response rates in portal vein tumor as compared to the main tumor. So main tumor does not respond that well, whereas the portal vein tumor thrombus itself, although it's supposed to be the same type of cancer, responds much better for some reason to radiotherapy. So in downstaging, we use a combination therapy, often TACE, TARE, and SBRT is often a combination. Either the sequencing might differ. You can start off with SBRT or end with SBRT, but SBRT is most important for downstaging portal vein tumor thrombus. That's the difference in concept. So briefly about outcomes. So there are multiple published studies. These two are Indian, Dr. Soin's group and Gupta's group. This is from Korea. I'll just cover one. So Dr. Soin's group, 11-year study of 2,000 plus patients, transplant of HCC 450, and for 45 of them, about 10% had portal vein thrombus, and downstaging was attempted 43 and transplanted 25 patients. And if we briefly look into, I'll just ignore these two, just focus on these two. This Kaplan-Meier curve shows you the survival of non-portal vein thrombus. This is the top line. The green line is the one with portal vein thrombus who were downstage. So statistically not reaching significance, almost similar outcomes. Whereas if we take all comers, even those who were not downstage but had portal vein thrombus but still transplanted, the outcomes are not that great, but still better than patients who did not receive transplant. So without portal vein thrombus, 5-year survival is 65%. With thrombus but downstage, 57%. And that's not what you have to compare. You have to compare this with this. If you don't transplant them, portal vein thrombus, you have a 2-year survival of 17%. And if you just give sorafenib or supportive care, none of them will survive in 1 year. So that's the huge difference which transplant makes. 57% 5-year survival versus 0% if you give sorafenib. Lee tried to determine some criteria which makes transplant futile in setting of macrovascular invasion. This is very specific to the portal vein thrombus. So these are the criteria. If any of one of these are there, then it's futile, which means they'll recur in a doubly quick time and it's not really worth it. So in summary, so standard criteria are too restrictive. So, and transplant can be safely offered to patients who are much more advanced, as long as you focus on biology and carefully select them. So multimodal therapy is the way. So, and moving from curative intent to is the important thing to prolong survival. It's not about achieving 70% 5-year survival. It's about achieving much more survival than other methods of palliative care. So I've just given there's much more to HCC. The entire conference is on HCC. I've just given a small taste of what it is, and hope you enjoyed it. Thank you.
Thank you, Dr. Sendil, for the excellent talk. You covered in a short time all the important aspects of advanced HCC. If the floor, is there any questions you want to ask the speaker?
Sir, thanks.
Okay, that you have shown that the recurrence rate in 2 years is quite high. So is it worthwhile in our country where we predominantly the LDLT is being done?
Yes.
Is it worthwhile to do this downstaging? I mean, downstaging and do transplantation? Is it advisable?
Yeah, that's what the whole concept is. If you downstage them, the results are, if they respond to the downstaging treatment, it itself is a selecting factor. they respond, then they have good biology. And as long as you can keep them on that downstage state for a good 3 to 6 months at least, and then transplant them, then they have excellent results, almost comparable to those who do not have or who fall within the Milan criteria, early HCC. That's all the whole concept is. Even if you don't downstage them, even if you still transplant them, results are much better than if you offer them any other single therapy. Like for example, if you don't transplant them, if you advance HCC, you just give them TACE or TARE or systemic therapy, sorafenib. The survival is not that great, as shown in one of the articles. So the 2-year survival will typically be about 5-10%, 2-year survival. I'm saying about advanced HCC. Whereas if you transplant them, so about 50% will survive beyond that, much beyond it. That's the big difference. It's not about curing. We are aiming at palliation. We are treating liver transplant as a palliative option, which is a bit difficult to digest. But that's what, as long as the family agrees to that risk, they understand it will recur. We have to explain to the family that it will recur, higher risk of recurrence than within Milan criteria. So as long as they accept and LDL is a private gift, then it's still ethical to go ahead. That's what the new concept is evolving, because previously they used to just shy away all these patients, never transplant, offer them transplant, and all of them used to die within a year's time.
So all these patients, you do biopsy before starting this stay there. And
well,
SBRT.
It's not necessary. If in a cirrhotic, we're talking cirrhotic patients. If you have in these more than 2 centimeter size lesions, if you have at least one modality which has classical features like arterial enhancement with the venous washout and capsular enhancement, all these features are there. If at least one modality is there which gives you classical features, then it's okay. It's good enough with the raised AFP. So it's not a must-do biopsy. But if you're going to offer only palliative treatments, then you're mandated to do biopsy. So we don't biopsy all patients for HCC for transplant. In fact, we advise against biopsy for transplant and for resection also. Should not be biopsying unless there are atypical features, mixed cholangio HCC, which we sometimes come across, AFP being normal, not classical features, even on contrast MRI plus CT. Then you go and biopsy, because you can sometimes miss rare tumors like, for example, lymphomas or other neuroendocrine tumors which have atypical features. That's when you have to biopsy. But classical HCC, which occurs in setting of the right setting should be right. Your imaging should be classical. Then you don't need biopsy.
Just a very concise presentation, sir. Sir, my doubt is, so you've been in both UK as well as in India. In UK, if you see, the criteria is very strict in UK, the Milan criteria, and the other thing is the robust disease donor program in UK. And there is a DCD program also. So even if there's a marginal DCD now with the machine perfusion, the DCD livers are being given to HCC patients. But in India, considering disease donor is not much an option now. And always you mentioned about the double equipoise. So what do you anticipate a minimal acceptable survival for to overcome the donor risk?
Yeah, I mean, it's a good question. Classically, they used to say at least 50% 5-year survival. That is for early cancers. We are talking about very advanced cancers where patients will not survive otherwise beyond 6 months to 1 year. And in this case, when the family agrees, then you're allowed to take the risk with the donor. So we are talking about palliation, not cure. So
because in India, always there is an emotional component of the family, because
that's true.
It's always like any number, any size criteria.
That's true. But that's where we have to educate the family and have multiple sessions of counseling, and they have to understand the risks. It's sometimes difficult when people are not very well educated enough to understand the medical risk and all. But we have to again and again reiterate that the risk of recurrence is high. They can't expect a cure. It's not cure, and you have to put it down in paper. And then if they agree to that, and then to that risk, and then who are we to stop someone living extra 6 months, as long as family is willing to take that risk? So.
One more last question. In your experience, how do you assess bad tumor biology for transplant?
Mainly by obviously size criteria, size and number criteria, and of course, and then we have PET avidity. If it's very high PET avidity, SUV max more than 5, that's going to be very bad. Or if you have very high markers, AFP and PIVCA2 in thousands, we do both tumor markers standard. AFP and PIVCA2 in thousands, then that's not going to be good. And then you have, of course, last option is biopsy, provided you're going to offer transplant. Like I had one of the slides I had actually extras I didn't want because short of time. I didn't want to do that. This is one actual patient we have in our hospital. We are going to offer transplant for him. And he's a 55-year-old gentleman who's got a MELD of 20, otherwise well compensated, and then he's got more than 20 lesions in the liver, more than 20 lesions, largest 3.5 centimeters, no portal vein thrombus, AFP-PVK2 are high, but not very high, not in thousands, and no extrahepatic mets. PET is not PET away. We did a biopsy in him. It's grade 2 tumor. So all are in favor of this being a reasonably favorable tumor. It's not going to be excellent. We don't expect him to be cured. But I think if we transplant him, he'll at least have at least 2-3 years of survival. We may have recurrences which are very much treatable these days with immunotherapy, with multimodal therapy. Recurrences are very much treatable. So we can give him extra 5 years. Who knows? Who are we to decide that he should not get that transplant? Family is willing. Daughter is willing to donate. And we have an advanced tumor. There's no other option. 20 tumors, this only takes one snapshot picture. Actually, if you go through the whole dynamics, fully studded with tumors, not one segment is spared. But still, we are going to offer him transplant because of exactly this reason. So that's how it is. You have to be careful about it. You have to use biology as well, not just number and tumor size.
Thank you, sir. As you clearly said, the change is from morphology to biology. And with the introduction of immunotherapy, things are evolving very fast.
No, LBS, no, we had a very strict criterion. We never used to go beyond UCSF. So I don't know whether or not they've changed now, but I've left past 4 years away now. So unlikely. So they're very strict about selecting, which is quite right. But the thing is, it's a very evolving field. Things are changing. The concept has changed. So from cure to palliation, because with the donor safety, it's very well established now. We can do donor surgery with amazing level of safety. So
with the advent of immunotherapy, bevacizumab and natalizumab.
Exactly. Yes, that's also adding another this thing, weapon in the armamentarium, so-called. So, but response rate is about 30%. Some case reports published are amazing. Total disappearance of tumor. But there's a case report. So
Muthu, why it's not followed in Relas Institute, Professor Relas?
I'm sure they are.
You need to attend ILTS 2024 to see my results. We are
they're
presenting a prospective trial. We have downstage with TACE with SBRT for portal vein tumor thrombus. Similar to the retrospective study from Medanta, but it is a prospective control trial with all the three. But in patients who are paying Atabeva, which is costly, we have now negotiated. We are starting another 2-3 patients with Atabeva as well. Before that, I used to use Lenvatinib. 5 patients have been done in 1.5-2 years out of 58 attempted downstaging. Longest survival is tumor-free survival is the first patient, 3 years. He's 23 years, who had HBV cirrhosis with portal vein tumor thrombus, SBRT, TACE and SBRT. This can be changed.
Yep.
It can
Absolutely.
be changed. It can be changed. And his sister donated. I think she's 18 or 19 years, and is 3.5 years, no recurrence. Second patient is a 60-year-old man who had similar history, but tumor biology was good. He had a aorta caval node recurrence, which is 5 to 10 to 15 mm. We are ablating with radiotherapy 2.5 years after transplant. No other.
Absolutely, that's the best option. No,
no
I mean, if
I won't agree even palliation. So.
Yeah, if I had given this talk 5 years back, people have stoned me down. The concept has changed. That's why I chose this topic when you called me. It's a very important change in philosophy itself. Thank you.
Please take the moment.
I'd like to give a memento to Senthil on behalf of our department. Next, we have the online talk by Dr. Srinath. So, Dr. Srinath did his MS from JIPMER. After that, he did his MCH from All India Institute. From there, he moved to US. And initially, I think he was at Nebraska University. I'm not sure. But currently, he's at Minnesota University, where he was doing the both the pediatric liver transplantation as well as the is also doing the islet cell transplant. He's involved with that. So the chairperson for his talk are Dr. Rajinikanth is not there. Dr. Senthil, myself, and Dr. Muthu Kumar can come, I think. Dr. Muthu. Dr. Senthil.
Hello, Dr. Srinath. Senthil here. Nice to see you.
Yes,
You're
yes.
junior.
Yes, of course. Can you see my slides, Sandra?
Yeah, just about, yes.
Fantastic. First of all, I want to congratulate Senthil. Senthil and me were residents together, and it's just with admiration that I listened to your talk, Senthil. Fantastic. Well done. And I'm glad to see you're doing all those advanced HCCs. So today, before I start, I want to thank Vishnu Prasad for giving me the opportunity. And it's a real privilege and honor to come back home, and JIPMER is my home. Thank you so much for this opportunity. I've been a staff now for almost 23 years, but the best part of my life was doing my junior residency in JIPMER. So everybody, I'm sure Dr. Anant Krishnan is on the in the audience, and Dr. Anant Krishnan, good afternoon. So these are the three individuals that we started. We started off in Unit 3B. It was a small unit. We had like 1 day of operating time. And the person in the center is GVS Prasad. He and me were the partners in crime. We were co-residents together, and I want to thank and acknowledge Prasad for the camaraderie, and he was always more energetic than me. And then the person ahead of us was two of them, Suresh, I don't have his picture, and then Ayyappan. Ayyappan was such a calm and talented surgeon that I learned to be calm from Ayyappan. Of course, Vikram had just arrived from Nagpur and was trying to get his feet on the ground, and we were able to work with him. And Vikram, if you're in the audience, thank you for all those good days. And then after I joined, we passed the first year, and then Shivam joined, and Shivam is actually online. Shivam was a fantastic, bubbly individual that kept everybody awake during the residency. And then, of course, we had Mohan Raja, as all of you know, he passed away, and Malhotra, Cherian, my classmate. And then we had Dr. Hadke and Srinivasan. But then after we moved to Unit 1, they got units of themselves. So these are the real, the best part of my life, surgical professional life. I learned a lot in JIPMER, but there are a few things I have to acknowledge particularly from Dr. Anand Krishnan. He demonstrated to us that whatever you do, the patient comes first. The second important thing that we all learned from Dr. Anand Krishnan is critical thinking. He always took history, examined the patient, came to a differential diagnosis. And I think that was something that is essential foundation for any surgeon. And of course, we were always disciplined very well in Unit 1. I always used to envy Dr. Robinson Smiles' unit, where all the residents got much more surgery to do. We didn't get as much, but boy, when we learned it good. So I think what I learned was quality is more important than quantity. And Dr. Ravindra, who's an outstanding surgeon and a great mentor to me, will be speaking there, so you'll be hearing more about him. A few other things that Dr. Anand Krishnan taught us was scientific inquiry. And the thesis was one vehicle, but he did ingrain that scientific inquiry. And also, he said that you have to learn how to collaborate with other departments. For example, I collaborated with Dr. Lakshmanan for a thesis in anatomy, and that was very helpful. The other piece is he also demonstrated that you have to have a niche when you're in a large practice, so that people know you and you publish in the field, and that really was ingrained in JIPMER. So from the bottom of my heart, thank you to all. And I'll briefly come to the less important part. I'll talk a little bit about causes of liver failure in infants, that is, children less than a year old. And I'll try to explain to you why infants are not little children. We'll talk a little bit about how to get these kids transplanted, a few words about ABO and comparable transplantation, and then I'll describe the experience we have here. This cartoon demonstrates to you the immunity that an infant has. So this is taken from epidemiological studies which show that an infant has the immunity of an 80-year-old. They don't have any developed immunity. So this explains what the development of the immune system. I won't go too much into detail, but essentially what happens is that the T cells and B cells are not well developed to produce an immune response in an infant. So what does that mean for clinical transplantation? Two things. One is that these children don't synthesize antibodies. So ABN comparable transplantation is very successful. But that's the upshot. But the downside is that they are very prone to infections, particularly the small children. We don't like to transplant children less than 10 kilograms, but sometimes you're forced. Like, for example, children of biliary atresia, like the ones shown in the picture, if they have very severe ascites or cholangitis not responding to medical therapy, or of course, when you have kids coming in with acute liver failure, or sometimes when you have children with metabolic liver disease, that particularly the urea cycle defects, that don't respond to medical therapy and have repeated attacks of high ammonia levels due to various causes. In those individuals, we are forced, and not by choice, to do transplants in these little babies. Now, this is the problem today in the United States, that among 10 children listed for a transplant, 2 of them die before getting liver. So it's that is very alarming. However, in our center, we've been a little bit fortunate in the sense that we try to liberalize the criteria for applying for MELD exceptions. And then we also have a living donor program. The types of livers that can be used in these infants is, as you are aware, the United States has the best disease donor program in the world. Like, for example, last year, there were 10,000 liver donors successfully transplanted. So that's the gift that we have available in this part of the country, in this part of the world. So for that reason, we have 2 options. One is deceased donor, living donor. Among the deceased donor, we do quite a few full livers. If the donor is more than 3 months old, you can certainly use the liver. And you can split the liver, use 2 segments. Sometimes if it's a younger donor, like for example, a 5-year-old or a 6-year-old, and you can't find a recipient for the other segment, then we just reduce the liver. And of course, the living donor transplantation. Now, in our center, we've been pretty aggressive in transplanting these children. So fortunately, for 12, almost 13 years, we've had 0 mortality in anybody that is referred to us for a liver transplant or was listed. This is an example of a reduced liver. In a reduced liver, this is a situation where I think the child presented at 6 months age, and the donor we offered to us was a 4-year-old. So we essentially lopped off the right lobe, and we had the entire vasculature to use. And this is quite successful. This is split liver. The downside of split liver is that, first of all, you have to go out and do this inside a split. And then the criteria for splitting livers are somewhat limited in the sense that you have to have a donor that's stable, donor that's less than 40 years of age. The AST and ALT should not be more than 3 times the normal. So although this is a really nice way of transplanting these kids, there are not that many livers that are available to split. Living donation, of course, this is I won't say that India certainly has the largest experience in living donation today. And for these infants, you can do a segment 2, 3, or even a mono segment. This is an example of a case that we have done. And as you can see, you can get a really small segment to transplant these little babies. The implantation in these infants is very important. There are three important aspects that you have to pay attention to. The first thing is the outflow. There should be no narrowing at the outflow, and if you have a wide anastomosis and the liver sits good, no congestion, then the graft function will be very good. And of course, the other area you have to pay attention to is the hepatic artery anastomosis, as the arteries are small. We personally don't use a microscope. We just use 6-0 loops. And if it's a single artery, we do end-to-end. If there are multiple arteries, then we end up putting an arterial conduit from the aorta. Now, this is the important aspect of transplanting children. Question is, these kids are small, so what is acceptable and what is not acceptable? In general, the current data suggests that the graft weight by recipient weight ratio should not be less than 1 and should not be more than 4, so 1 to 4. What happens if you put a big liver? If you put a big liver in a small kid, then there is insufficient flow to perfuse the liver. There is inadequate tissue oxygenation that results in graft dysfunction. And the size itself can cause compression. So all these combined can cause graft failure. So in general, the current accepted is 4%, but we have been fudging a little bit, going maybe up to 6%. And I'll show you how we do that. Yeah. So first thing is, not all donors are the same. For example, this is two different donors, both of them about 70 kilograms. As you can see, one of them has what we call as a leaf type of liver. So that liver is easy to fit into a small recipient. The one on the right side, the bulky one, that is a liver that is difficult to implant into a small baby. So we generally, when we evaluate donors, we try to pick the donors that have leafy left bowel segment. Similarly, not all recipients are the same. These are two children that are 7 kilograms. And as you can see, the critical point in transplanting these children is the anterior-posterior diameter between the xiphoid process and the vertebra. So that is the limiting factor. So as you can see, all children are not the same. There are some that have larger AP diameter and some less. So the picture below, that's the patient that you're able to give a larger graft. And one way when we do more than 5% or 6%, particularly we use a mesh. This is an example where we do a primary closure. We use the permacol mesh, connect the mesh to the fascia. And then fortunately, a lot of these children, you can easily lace flaps. So as you can see, we have raised flaps and closed the abdomen. The other thing we have noticed is that if you put a small liver into a child, it grows. And if you put a big liver, it shrinks down within about a week or so. So using that strategy, we have employed similar to the Toronto group, where we close the abdomen with a silastic mesh, put them on a wound bag, and then go back and do a stage closure. Sometimes we do it 3 or 4 times, and in all instances, the liver has decreased in size, and we have been able to successfully do that up to 6%. This is personally not my favorite. My opinion is that an operation to be successful should be performed by any average surgeon. And this is something that I'm sure the talented surgeons can do. you have to kind of very carefully carve out segment 2 and remove the 3. So this is not widely practiced. I think a meta-analysis that I looked at showed that there are 21 cases from all over East, which showed a survival of 85%. Now, this is what we practice, or I practice, in which if you have a leafy left lobe, right? So the anterior posterior diameter is not a problem. It's just that the liver is flapping, and you can easily divide that with a stapler. And for example, this is a case of ours where we had a 6%, and then we lopped off the lateral part of the left lateral segment when we were able to reduce it to 4%. So those are some of the tricks you can employ to provide an appropriate size match graft to your little baby. Now, one of the problems of operating on these children is that the vessels are small. So in spite of the best technique, they can have thrombosis, and which is very devastating. So one of the things that we have learned is that if the little livers don't produce antithrombin right away, if the antithrombin levels are low, you end up getting hypercoagulability and thrombosis. So we routinely check antithrombin 3 levels in these babies. If it's less than 80%, we give them external replacement. And of course, the practice of anticoagulation is dependent on the center. We use it quite frequently for when we do arterial reconstructions out of their technical issues, and we use a combination of heparin or dextran or aspirin. The one other thing that we routinely do is ABO incomparable transplant. So this is like a 3-month-old that we did a ABO incomparable who got extubated on table and got discharged within 5 days. Like I mentioned earlier, these children don't develop antibodies when you do ABO incompatible. This is something that we had copied from the cardiac team. This is the Sentinel paper from the Toronto or the Canadian group that showed that ABO incompatible heart transplant was successful. It's also interesting that when you do the ABO incompatible transplant in a child that is less than 1 year, they develop donor-specific P tolerance. That means that they don't, they develop tolerance to the anti-A or anti-B antigen, and in future, they never develop antibodies. So that is very unique for children less than 1 year of age. There are many protocols being followed in various centers. This is just one of ours. And we tend to use induction thymoglobulin. And then we also check an antibody titer before the transplant. If it's more than 1 in 8, we reduce the titer by doing plasmapheresis. And of course, we follow them closely and do biopsy at 3 years and 1 year. So this is our experience. The major advantage of doing ABO incompatible transplantation is, as all of you are aware, the commonest blood type in at least in the West is A followed by O. And the less common is A, B, and B. So there are not that many livers, children listed with AB blood type. So there are quite a few AB livers that go unused. So by doing an ABO incompatible transplant, we are able to utilize those livers. Not going into too many details, these are the indications as you can see in the slide. But the most important thing I want to draw your attention to is that even if you do an ABO incompatible transplantation, there is no increased risk of arterial thrombosis, and we have had 0%. The rejection rate also is not much, and we have not seen any antibody-mediated rejection using the protocol with thymal induction. Like I mentioned to you earlier, in infants, once you transplant them, they develop donor-specific tolerance. So the problems we have had have been very early on, and after that, we have had no issues. So once you do a successful transplant, these children do well afterwards. There are many rewards of doing pediatric transplants, but one of the difficult part is when you lose a child. And for me, I never forget the deaths I've had. I've had 2 deaths in the last 15 years. One was a 2-month-old that had fulminant hepatic failure. We, during the evaluation process, did a liver biopsy, and the kid bled from the liver biopsy. And then we did a CT scan to make sure everything was fine. And we took the patient to the operating room, and the entire ball was gangrenous, but we just took out the gangrenous ball, implanted the liver. There was no flow, and patient died. The second one was something that I'm not sure of the cause. This was a 4-month-old. We reperfused open clamps, and then it caught just arrested and could not be revived for CPR. And we didn't know the cause, but upon review, the ionized calcium was high, so it could have been a high inadvertent dose of overdose of calcium being used. So those are the 2 deaths that we have had. Of course, the rest of the country also does ABO incomparables, but as you can see, there are predominantly done in children less than 1 year, not so much after 2 years. So what are the nuances in little children regarding drug delivery? The first thing is that the physiology in these little babies is different in the sense that they have different gastric pH, they're slow emptying, the intestinal transit is shorter. There are also differences in the extracellular and intracellular fluid. And then this cytochrome P450, which is the primary determinant of tacrolimus metabolism, is also at much lower level. So what does all this mean to us? That children at younger age have toxicities. They have renal failure, hypertension, cardiomyopathy, neurotoxicity, and all increased risk of PTLD. So in general, for these young children, because of their physiology, the lesser immunosuppression is better. So we tend to target lower levels, in generally 6 to 8 of tacrolimus in these children. And then the other piece is that since they don't have much immunity, they tend to develop a higher risk of both viral, bacterial, and fungal infections, particularly viral infections. So the less immunosuppression is better for these children. So what are the outcomes worldwide? Nobody has a large series. So this is a series compiled from about 16 centers in the United States and Europe. And as you can see, the 1-year survival is about 85%, and 5-year survival is about 72%. And the complication rate, as expected, is pretty high. The vascular complications in this particular series was about 12%. The biliary complications were 15%, and then every second patient developed infections, and retransplantation rate was about 16%. Our experience is as follows. We have had a tad better survival compared to the series that you've seen earlier. The graft loss we have had is in the first week, really, and then after that, we have done quite well. So the survival is about 90%. And once they've crossed that 1-year mark, we have never lost a patient or a graft. So we've had almost 90% at 10 years. This is a similar picture. Now, what is the difference between ABO compatible and ABO incompatible? As you can see in this patient survival, the ABO incompatible is a tad lower than the ABO compatible. But as I mentioned to you in the 2 deaths we have had, those were the ones that occurred right here immediately in the first postoperative day. But if you remove those, I believe the survival would be similar. Even including those, statistically, there was no difference between ABO compatible and ABO incompatible. This is a similar graph showing survival, Kaplan-Meier showing the graft survival. The differences in patients, really the ABO, there's not statistical difference between the type of patients we have transplanted using comparable and incomparable. One of the important things to note in these transplanting little babies, particularly the young ones, is that they tend to stick around in the hospital for a long time. At our institution, the average day length of stay in the ICU is about almost a month. And but the good news is that we are fortunate that we have had very little vascular complications and graft losses. So in conclusion, infants are not little children. They tend to have less immune response, and thereby ABO and comparable transplantation is very much possible. Technical innovations are required to transplant these children, and certainly anticoagulation is a good method of preventing vascular thrombosis, and overall the results are excellent. Clearly, I want to, this is a lot of hard work. I'm sure those doing transplants understand, but when you get these pictures, it is really gratifying. Like, for example, on the right upper quadrant, you see this little girl here. She came to visit me in the clinic at 1 year. So we took a picture with these two little bears, and I couldn't, her bilirubin was like 65. And I couldn't tell if she looked yellow or green, but anyway, a year later, she is doing pretty well. And the smallest we have transplanted is a 3.1 kilogram child. Of course, like Dr. Ananthakrishnan taught me, it's important to have a collaborative team. So these are my colleagues, partners that we're two surgeons. I take turns doing these transplants, and we also have a robust fellowship program as well. And I worked very closely with a lot of pediatric hepatologists as well as coordinators and posts. So with that, I'll stop. And again, I wish I could have been there in person. I will get there for one of the alumni meets, but maybe the Silver Jubilee one. But I want to thank Vishnu and the entire JIPMER team for giving me an opportunity. And it's a real honor to hear all my colleagues give those wonderful talks. Thank you, and appreciate it.
Thank you, Srinath, for a very lucid and comprehensive presentation. Professor Ananthakrishnan sir is here. Actually, he was listening to your talk. He's going to have a chat with you.
Good morning, Dr. Ananthakrishnan. Good morning, Chief.
Hello, Srinath. Nice to hear you.
Yes, thank you. And just for the people in the audience, during those days, we had so much respect for Dr. Ananthakrishnan that we only called him a chief. When we would see a patient, we would write there, seen by chief. We didn't ever write Dr. Ananthakrishnan. So that much is the respect that we had for him.
Yeah, whenever somebody asks me where you learn your transplant, I say I learned it in JIPMER from Prof. AK because basics are important. No, you can learn anything after that. So if your basics are right, I think that's what's most important. Thank you. Any questions from the floor? So I have a couple of questions, Srinath, if it's okay. First of all, I'm sure you did in your series, quite a few must have been biliary atresia patients.
Right. That's correct.
I just want to know what will be a protocol for managing the atretic portal vein. Sometimes you get very atretic.
Yes, that's a very good question, Santal. The first thing is the preoperative imaging. We are now routinely performing a CT scan with a portal venous phase to understand the collaterals. That is very, very important. And in general, if the portal vein is more than 5 millimeters, they tend to do well with end-to-end anastomosis. If it's 5 millimeters or less, then you have to be very careful. So our practice here has been that we go all the way down to the junction between the splenic vein and the mesenteric vein. And usually at that point, confluence, you tend to get a bigger diameter to anastomose. That's one. There are, if you have a living donor, obviously the graft is small, so you can put it into position. If you have a deceased donor, then you're able to do that. Then after we do the anastomosis, we actually measure flows using medicine stem flow meter. And in general, the flow has to be about 100 ml per 250 grams of liver tissue. So if it's less than that, then we would go ahead and ligate we routinely ligate the coronary vein, but we go ahead and ligate all the collaterals. There have been instances where, in spite of doing that, we don't get any flow, right? So in those instances, what we have done is we have actually taken the left renal vein, divided it at the IVC, and used that as an inflow for the liver, and has worked quite well for us.
Okay, thank you. And the other question is, I saw you use ATG in the OR itself. In young children, obviously the immune response is very minimal. Is there a need for ATG? Is it not an overkill, or is the standard protocol across hospitals in the US? Because we don't tend to use ATG in children.
Actually, I'm glad that you brought that up. I've been asked this many times. You can, of course, do the ABN compatible with basiliximab, etc. But the one advantage of using thymoglobulin induction is that you get donor-specific tolerance. If you use basiliximab, for example, then you will not achieve the tolerance. So the advantage of giving thymoglobulin is that it completely eliminates the immune response, immune cells at the time of implant of the graft. And then subsequently, those B cells don't wake up. So that's the advantage of thymoglobulin. The long-term donor-specific tolerance is better achieved with thymoglobulin. That's the upshot. But the downside is, of course, with thymoglobulin, you have increased risk of infections, particularly the viral ones in PTLD.
Okay, thank you so much. Thanks.
Thank you, sir.
Just one question, Dr. Sheena. If there is a biliary complication in such small babies, how will you manage? I'm just curious to know. Biliary.
Yeah, very good. Very good. The first thing clearly is prevention is better than cure, right? I learned that at JIPMER. First thing is do the operation correctly. I think when you do the bile duct, it's very important to trim the bile duct to make sure the vascularity is good. The second piece is similar to the arterial anastomosis, we use high magnification. We routinely use 6.0 magnification to do the bile duct anastomosis. The other thing we do is we tend to put a stent in. Typically, we use a urethral stent with a C-loop, so that keeps the anastomosis open at least for a while. And now, if the bile duct leaks, very clearly the treatment is reoperation, no question. If the bile duct strictures, then you could do, for example, if you've done a duct to duct, then you could do an ERCP and put a stent. The picture I showed you of a 3-kilogram baby, we were able to do a duct to duct, and that patient strictured, and we had our ERCP doctor go in and put in a stent. But for the Roux-en-Y strictures, you have to do PTs.
Can I ask a question?
Please.
How many of I'm a pediatric surgeon, so how many of the, following the Kasai, how many months or years after the Kasai you are doing all these children? Most of them, or are you doing any primary transplants too, without the Kasai?
Oh, yes, that's a very good question. The first thing is anytime there is a patient with biliary atresia, whatever the level, whatever the time of diagnosis, whether it's an early diagnosis or late diagnosis, we always recommend to go ahead and do a Kasai procedure. That is for sure. Because there is a small percentage of children that will respond to the Kasai. So we generally do not transplant without Kasai procedure unless they have acute liver failure.
जल्दी से गाड़ी पार्क करके मैं वॉशरूम यूज करके आती हूँ.
And the second piece is the indication after? When do you call a Kasai to have failed? Very clearly, if they have recurrent cholangitis, if they have synthetic dysfunction, or if the child is not growing or they develop complications related to liver disease in terms of ascites or variceal bleeding, those are the indications. But the response to Kasai, as you're fully aware, is dependent on the type of biliary atresia, right?
Thank you.
Thank you, Dr. Srinath. That was an excellent talk. I congratulate you on that. So the next talk will be by Dr. Ravindra. Before that, we have just a 5 minutes talk by Dr. Shivam on his book. So if there is no objection from anybody, it's actually a talk on a spiritual book. If there is no objection, I can just allow for 5 minutes. So Dr. Shivam, it's, can you, yeah. So,
thank you, Vishnu, and thank you, Srinath. Thank you, Sendil, Sir, Dr. Ananthakrishnan there. It's homecoming for me too, Srinath, and it's awesome to see you all. And I just was messaging Ravindra on the chat. Very humbling. I mean, it's just mind-boggling to see the amount of progress and work that has happened. I'm coming back home, imagine 30 years after, and as a child coming back home, that's exactly what I'm feeling like. And I've never spoken about spirituality in my life. So this is the first time I'm ever talking to an audience. So bear with me if this is not making any sense. But what I wanted to do was, when I was humbled by all the talks, I just wanted to share something which I was humbled even further. And I thought that's awesome. And I just couldn't not do that. And when Vishnu Prasad gave me this surprising opportunity, I just said, look, it's delightful and thing to share this. So I'll just quickly go through. I got only 5 slides, but all I wanted to say was, as doctors, where does spirituality come into this picture? 30 years back, if Chief had asked me and told, when you come back, what you're going to come back to say, what you've done in life, I don't know. In those days, we were doing quite a lot of stuff, quite heroic. What did you learn? I just want to say that, look, I'm just coming back to share that at the age of 53, you can still discover things. And what you discover is possibly much beyond liver transplants or bringing back life. You guys are doing awesome things. You're doing phenomenal. Srinath, to see that child survive, Sendil, to see that hepatocellular carcinoma. I mean, there were times when we saw those hepatocellular carcinomas in our clinics and we said goodbye just in the clinic. And now you're talking about portal vein thrombosis. Where does this all lead to? And what is the outcome of all of this personally to us as clinicians? And that's where, it humbled me when I came to know God in a much more truer sense. And then I wanted to share that. And that's where this whole journey came about putting it into my book, which I've just released. And so what is effectively, I mean, in the next 3 to 5 minutes, I'm just expecting that all of you are not going to look at this as a randomized controlled trial, but you're going to look at it as children along with me. So please come into this journey for 5 minutes and treat yourself as children. Imagine your father was talking to you at 3 years or 5 years or 8 years of old and was trying to teach you, guys, what is going to be there in life going forward. And for me, what was phenomenal when I had this experience, I'm not saying that I'm anywhere holier than thou. I am the worst of all persons you could possibly meet. So I'm not saying that I'm in a spiritual highland and I'm one guru here. But what has happened through this transformation process of knowing God truly has been a humbling process. And it has essentially made me to love God and love one another more. when I'm seeing all these presentations, like Srinath showing those children, ultimately what I think goes on behind every surgery there, behind every patient we see there, is that love. I still remember our OPD days, we were calling them left and right sitters. Oh, remove your trousers, remove the side, put the fellow on the left-hand side. I'll be 50 cases we'll be seeing in an hour. We never actually had that much of, I will say, moral love in our hearts. We were technicians, and we still tend to be technicians. But when we look at each one of our patients and look at it as a labor of love, that changes the whole picture. That changes the whole outcome, not just for the patient, but for us and for our teams. And that's why I felt sharing this discovery was fundamentally more important to me than having been just a pure surgeon. I'm in these days, I do a lot of work in technology, and I'm working a lot in artificial intelligence. And I can tell you, human pride can take us to any level where we just go beyond what we can do. But God definitely keeps us humble. And that's what I think wanted to share through this book. So effectively, what does God mean? I mean, I'm not talking of Christianity or any of the religion as in specific, but I'm just using the Bible as my source. But anyone can use what your source is. But essentially, why believe? Why believe? Why do you want to have a spiritual force? I know quite a few of you, in fact, brought spirituality in your talk, even without knowing about it. But I think the most important thing for us to realize is ultimately, who am I? Why am I here? What are we doing all this for? What is the ultimate aim in all of this? And I think in every piece of our work, in every IV infusion we are starting, or a liver transplant we are doing, or in every life that we are restoring, I think what we are achieving there is glorifying the Creator. I think that's the key thing for us, to be humbled, to believe that the work that I'm doing is going to glorify someone more superior, more senior than us. We all humble our teachers there. Every time, like Srinath said, we just love our teachers. But imagine you did this much more than that your work, you sacrifice, you give it to something more higher than that. That will phenomenally change your outcome and your outlook to how you treat your patients. So that's sort of one of the discoveries that I made. But believing in God as surgeons, as scientists, as clinicians is often very hard. And I can't do a randomized controlled trial to prove the existence of God or the benefit of belief. And that's why, very often, in our younger days, specifically when we are in the youth and when we are in the prime of our arrogance, let me put it that way, we tend to, put God away. We tend to put the supernatural away, and we just find the best means. I still remember the days where we used to battle the hematemesis with zinc stick and tube and all that. I just can't believe that we went through some heroics in those days. And then you guys are doing enough heroics today. But at the end of the day, why we need to be under the belief of God is that it humbles you. It brings you to a place where you can accept failure, where you can accept complications, where you can accept death, because there is something greater than that which is out there. And I know it's very hard for belief, because what God says is often very tough for us to accept, because it purely kills our pride. As humans, anything that we look at from a supernatural perspective, it kills our pride. It brings us to a state of surrender, belief, and therefore we feel pretty exposed. So we don't want to actually believe, and we try to go away from that. And then, and then there is this challenge of religion versus faith. And, I've seen that, in my own life, 50 years, I think religion actually kept me away from true faith. And true faith is nothing but truth. And that's where, understanding the truth in what we are doing, in how we are doing things for people, makes more important thing. That is, the faith matters rather than the religion. The religion is just the ritual. The faith is the truth. So I try to bring out quite a few of these things in my book, and it was a joy to write that, because I felt that ultimately, when you want to share, we write. I mean, I've written books in medicine. I've written articles. I've published articles. But for me, this was fundamentally a greater truth to share, a greater best practice to share. That belief in itself enhances our lives as surgeons and doctors. That's all I wanted to share. And thank you, Vishnu, for giving me this opportunity. But it was more important for me to actually see I was transported back to our Blalock Theatre with Chief and Dr. Smile and Dr. Jagdish and Dr. Vikram Kate and all of them sitting there and teaching us. But I think there is something beyond all of that which can teach us. And that's what I wanted to actually open up in this book. Thank you. Thanks, all of you.
Thank you, Dr. Shivam. Sir, would you like to say something? The next talk is by Dr. Ravindra KV from the Duke's University. Dr. Ravindra KV did his MS from JIPMER, and following that, he did his MCH from SCPJ in Lucknow. And then he moved to Leeds, UK. From there, he went to, I think, USA at the Duke's University. Now, currently, he's professor of liver transplant surgery at Duke's University. Over to you, sir. You can start.
Thank you so much, Vishnu. This is a unique honor for me to be able to present here, and really a privilege to follow Srinath, who's done outstanding work, and he's been in many ways, a leader. He came to the US ahead of me and has guided me significantly since then. I'm going to share my screen here. Just let me know if this, can I share my screen? Yeah. Are you able to see this now? Sorry. Can you see my screen, Vishnu?
Yeah, yes, sir. Yes, it's visible.
Yeah, thank you. So my brief today is to talk on hilar cholangiocarcinoma, perihilar cholangiocarcinoma, and it's really reflects the way my career has unfolded from just being a theoretical part of pathological curiosity to how we can really impact patients clinically in this part. And I'll go through this, how it, I followed this, my career really unfolded with this particular entity. Disclosures, I have no financial disclosures regarding this talk, or will I be discussing any non-FDA approved drugs as we are required in the US to declare. My aims today will be just review some of the anatomy pathogenesis of this perihilar cholangiocarcinoma, some historical perspective, and current management strategies, particularly with relation with regard to liver transplantation as a viable option for this particularly deadly disease. For those, if some residents are there, this is just to highlight that cholangiocarcinoma is actually a mixed bag of three cancers. One inside the liver, intrahepatic cholangiocarcinoma. Perihilar this is the one I'm talking about. It's somewhere between the cystic duct and the second order branching of the biliary channels in the liver. This is actually the commonest type of cholangiocarcinoma. The distal one behaves more like a periampullary cancer, and this is distal to the cystic duct up to the ampulla oblator. So the location is very crucial for this, as is shown in these CT scans here. The commonest, as I said, is anywhere between cystic duct right up to the second order branching here, and that's where has been the challenge for clinicians, surgeons particularly, for a long time, mainly because it's not common. So we cannot develop huge amount of experience on this particular disease, and that's why progress in this particular entity has been slow. My first brush with perihilar cholangiocarcinoma was in pathology. This is Robinson Cotran, the book we followed. I think it's still used as the textbook in JIPMER as well. Currently in the 10th edition, we were dealing with 3rd edition. That shows how old, how long ago I was in clinical, I started training. And this original paper in American Journal of Medicine 1965 was where Klatskin, an internist at Yale, he published this and said this is a distinct entity. And that's how this name goes by Klatskin. Although 10 years earlier, a different individual, Altumir, actually described this. But he's been forgotten, although it should have been called Altumir Klatskin. It goes by Klatskin tumor. Just reflecting back, my JIPMER days, I spent a decade of my life, possibly the most important part of my surgical career. My medical career was spent there. And this is the thinker statue, which is seen there, which is a Rodin statue. And I hope it is still there. And the last time I went there in 2012, it was still there. That was the 30th anniversary of our MBBS batch. And the statue was still there between Lister House and Curie House, somewhere in that small triangle area. And during that same time, I had the privilege of meeting both the stalwarts of JIPMER. I had the best of both worlds. I did my surgery residency with Dr. Smile in Unit 1 then. And then after finishing my MS, during that time, Dr. AK had become the chief and head of the surgery unit. And I did 9 months of senior residency with him. Of course, Dr. AK was the examiner for us. And suffice it to say, at those days, we were not dealing with cholangiocarcinoma in a surgical sense. But more importantly, what I gained was the intellectual honesty, simplicity, core values of ethical conduct in daily life, whether it's surgical, outside the hospital. These are in many ways much more important than surgical skills itself. And this is what both these individuals imbibed in us. I was a senior resident in the same unit at the same time as Dr. Kate. Vikram was my co-senior resident in the unit. And Kadambari, who is now a professor at JIPMER, was my classmate in MBBS. So at that time, this was, as I said, more of a curiosity. Not much was known, not much was being done. When I moved on to Sanjay Gandhi PGI at Lucknow to do my MCH, Professor Kaushik, who's no longer with us, he passed away a couple of years ago. He was trying to lead a lot of efforts. He was the only second program in the country to start MCH then. We gained a lot of experience in benign hilar surgery, but it was all mostly restricted to benign biliary stricture. At that time, lap chole was exploding in India. There were plenty of biliary injuries, and these were being transferred to Sanjay Gandhi at the time. We almost did 1 to 2 stricture surgeries a week at the time. Vast experience we gained, but not so much in cholangiocarcinoma. We were still cagey about liver resections. It was not known in the early 1990s what to do with hilar cholangiocarcinomas. But fortunately, we crossed paths with surgeons from Nagoya University. Sanjay Gandhi had a unique tie-up with Nagoya University, and the surgeons from there would visit us and discuss these options. The reason Nagoya is important in the landscape of hilar cholangiocarcinoma is this individual, Yuji Nimura. He was the head of, he was the chief at the first department of surgery in Nagoya University. And he essentially crystallized what needs to be done surgically to tackle these tumors for resection. And what he described in 1919 World Journal of Surgery stands true almost till today. These are the very principles that we have embraced. Till then, the bile duct would be divided and a Roux-en-Y hepatococcygeostomy was done. He said that was not sufficient. We have to do a concomitant liver resection in order to get oncological margins. He also emphasized lymphadenectomy. The hilum and beyond had to be, the lymph nodes had to be resected. And he emphasized very crucial point of caudate lobe resection, because the hilar tumors drain into caudate lobe on both sides, right, and whether it's right or left duct, caudate lobe had to be resected in order to get oncological margins. And this is a very unique contribution. And because of our tie-up, we got a glimpse into this early glimpse into what to do with these hilar cholangiocarcinomas. Although I was not trained at the time anywhere surgically, we read about it and discussed it with them. Satoshi Kondo and Junichi Kamiya, who were authors in this paper, both visited us and spent 2 months with us at Sanjay Gandhi, teaching us some of these techniques. This figure is more about the Japanese lymph node classification, which is very elaborate, and not widely followed, but they played a crucial role in the evolution of treatment of hilar cholangiocarcinoma. My next stop in my training and my career was in Sanjay Gandhi. After Sanjay Gandhi, I worked in St. John's. Not much progress on learning about cholangiocarcinoma. I trained as a fellow at St. James University Hospital in Leeds with a scholarship, P.N. scholarship. I went there and worked with this great individual, Peter Lodge. He is an excellent surgeon. Hepatobiliary, I've not yet to come across somebody with the finesse with which he deals with the hilum. And we published a paper. I was a co-author in this left hepatic trisectionectomy, arguably one of the most difficult liver resections. A third of this group of left hepatic trisectionectomies were actually hilar cholangiocarcinomas. And this was the first time I learned how really I felt confident about dealing with tumors in the hilum, learned the technique of aggressive surgical resection, lymphadenectomy, vascular reconstruction too. So that was the surgical part. But unfortunately, when we did the analysis, recurrence was very common. These patients, they would come back with recurrence local as well as distant, mainly local, within 6 to 12 months. So despite the heroic surgeries, we were not making much progress oncologically. And I'll talk about this. This is just to go back to, transplant has been considered as an option for cholangiocarcinomas, both intrahepatic as well as hilar, for a long time, starting from Starzl in Pittsburgh in the 80s, late 80s and early 90s. But this is Cincinnati tumor registry data from 2000, transplant tumor, crystallizes the experience up to that point of time that 66% of those who got a transplant in this earlier era died within less than a year, 8 months, 8.4 months. And most of them had even those who had incidentally found tumors, this is intrahepatic, they would have a nearly 2/3 recurrence. So you can see the 5-year survival for post-liver transplant at the time for cholangiocarcinoma was just 23%, which is totally unacceptable. Therefore, this was discontinued as a therapeutic modality for cholangiocarcinoma in the US, and the UNOS would not permit livers to be used for this purpose. Next part of my training, I followed actually Srinath to University of Nebraska, and this is a seminal paper which rekindled interest. And Srinath, who presented before me, was a co-author in this paper, which for the first time showed that adding neoadjuvant chemotherapy and radiation prior to transplantation might provide a window for long-term survival. So this was a very small experience, but that kindled interest. And this was quickly adopted in large scale by Mayo Clinic, and I'll show the results later. For those who are in the audience, trainees, this bismuth correlate classification, which is more than 35 years old, has withstood the test of time and is the simplest classification for these hilar cholangiocarcinomas. And this is, despite modifications coming about, this guides therapy even today. Diagnosis of perihilar cholangiocarcinoma is very difficult, elusive because of its location. The tumors are tiny and they're in these bile ducts, which are hard to really do get a good tissue sampling. Prior to treatment and diagnosis, one has the basic clues we get is a malignant appearing stricture on imaging. And to prove it, endoluminal biopsy cytology is done. Positivity is shown in some cases, very small number actually. There's a new technique, technique by Mayo, which is about 20 years old now. FISH, fluorescent in situ hybridization, where they show polysomy of the chromosomes, specific chromosomes, and the CA19-9 and a mass lesion at the site of the stricture. These are clues that we are dealing with a hilar cholangiocarcinoma, even in patients with primary sclerosing cholangitis. This is a picture just to demonstrate the type 1 Andre bismuth. You can see in the cholangiogram, abrupt cutoff just below the hilum. This is a type 2 stricture where hilum is disconnected, the two ductal systems, and it's growing actually into both the ducts, right and left. Biliary cytology, as I was mentioning, various categories we get. The pathologist is going to report them as non-diagnostic, normal, atypical, suspicious, or positive. There's no question about it. We're dealing with a definite cancer, and treatment options open up after that. Conventional cytology, however, has very low sensitivity, only 15% positivity, 38% positive. If you combine positive and suspicious, only a third of patients we are able to have some semblance of diagnosis in these patients. and 30 to 40% with suspicious will ultimately will be proven, if especially without a mass, they'll finally be proven on follow-up to have a cholangiocarcinoma. Fish, which I was talking earlier, this basically polysomy of chromosomes 3, 7, 17, and a few others. Where this is seen is in the setting of a dominant stricture. If you see polysomy, this is highly suggestive of cholangiocarcinoma. And especially, this is widely applied in Mayo Clinic, not so much outside. They've had very good results. We've had a hard time replicating the same results, but it's a useful guide for diagnosing these very difficult to locate cancers in the bile duct. So management, let me go to the management of perihilar cholangiocarcinoma. Two distinct groups. One is associated with primary sclerosing cholangitis. This is where the underlying liver is diseased. There is functional derangement of liver parenchyma. Resection in these patients has very high morbidity because of potential for liver failure. There may be early portal hypertension in these patients. So resection is possibly not a good option if they have underlying PSC. On the other hand, the de novo, where there is no associated liver disease, underlying parenchymal liver disease, resection is possible, and transplantation is an option in a certain subset, which I'll be discussing. And unfortunately, when candidates are not suitable for either, which is the majority, in fact, we only have very few options, and survival is not good. So what are the criteria for unresectability? I want to focus more on transplant, so I'm not going to go into all the details. But essentially, 1, 2 are very well known: distant metastasis or lymph node metastasis beyond the hepatoduodenal ligament, that is going to nodal zone 2. These are essentially unresectable. There's no advantage. It becomes a technical exercise after that. But conditions where the lymph nodes are not, where 1 and 2 don't exist, but they're unresectable due to either bilateral ductal extension beyond secondary order of biliary radicals, or the main portal vein or main hepatic artery is involved. Although some series have said we can resect and reconstruct, the results are not very good. Secondary bile duct, you have bile duct on one side and vascular involvement on opposite sides, so it makes resection impossible. Or lobar atrophy and the vasculobiliary involvement on opposite sides, which makes, again, resection sometimes technically challenging. So in those instances where there is no lymph node positivity beyond the hepatoduodenal ligament, they could potentially be candidates for neoadjuvant chemoradiation and the liver transplant, provided they have negative node disease. This is a very highly select group. I want to re-emphasize that this is not, this has to be these patients have to be very carefully chosen for a liver transplant. So principle of surgical resection, the aim of cure is, the aim is always going to be an R0 resection, margin negativity. Despite the progress that has been made, last 20 years, we have not really moved the needle as far as outcomes for surgical resection, because by the time we diagnosed, the disease has spread beyond resection, just like pancreatic cancer. Morbidity is high in resection, various series, 40 to 70%, depending on how rigorously the morbidity is calculated. Mortality of 5 to 15% still, and local excision of only bile ducts is strictly to be avoided now. That is no longer an option, because we are not going to get an R0 resection, and lymph node clearance is not achieved sufficiently. So a major hepatic resection with extrahepatic bile duct resection will increase the chance of R0 resection and long-term survival in these patients. Again, I won't go into details, but to emphasize again, caudate lobe resection is recommended in most. Lymph node dissection is done, but more likely it's prognostic. Very few series which have shown that anything beyond 1, even if level 1 is involved, sometimes the results are not good. It's a marker for already disease that has spread outside the hilum. Liver resection with excision of bile duct, R0 resection is possible, and intraoperative frozen section is recommended of the distal bile duct margin, or the proximal into the right and left ducts, and re-resection. But whether it really changes the outcome is, again, controversial in these patients. This is a papillary, just to show, but if students are present, just to show them little here. This is a cholangiocarcinoma arising papillary type in the left hepatic duct. Nothing was done for 6 months, unfortunately, and it spread to involve the hilum. and it extended into the right ducts, as is seen here. But since it hadn't spread beyond that, papillary have a favorable prognosis. We were able to do a left hepatectomy, extended lymphadenectomy. You can see the complete skeletalization here of the right portal vein, right artery, which is to the remnant right lobe seen here. Vena cava is completely exposed, and right anterior and posterior bile duct are ready for anastomosis. So this is the degree of clearance that is required even to have a minimal good chance of R0 resection and long-term survival in these patients. I'll quote the MSKCC Memorial Sloan Kettering data here, 2022, which they published and has not really changed much since then, where margin is negative R0 resections at 60 months, 5-year survival is still about 40%, and slightly better in some series, but overall that's a good number to quote. And R1, and if margins are involved, obviously it drops by half. It's only about 20%. And of course, these are definitely better than no resection, where there's hardly any survivors at 5 years with no resection. So survival data after this tumor, as I mentioned, Jarnigan from MSKCC published just 2 years ago. 5 years survival still stands at 40%. And unfortunately, recurrence after resection remains very high. Nearly 3/4 develop recurrence, most of it local, often distant. And there is no proven or really effective neoadjuvant or adjuvant therapy for these patients. Despite a lot of studies going on, we have yet to nail down a regimen that's going to work in these patients. Hence, for tumors that are unresectable, which we already discussed earlier, major vascular involvement, bilobar involvement, or insufficient hepatic reserve, as in the case of PSC, primary sclerosing cholangitis. What would be better than a total hepatectomy, regional lymphadenectomy, followed by liver transplantation? So I'll focus now next few slides on this. So the basic advantage of neoadjuvant therapy as far as cholangiocarcinoma goes, hilar cholangiocarcinoma, is that these lymphatic channels and perineural invasion, which is almost always going to be there, they get sterilized before surgeon violates these planes and causes dissemination. So they get sterilized by the radiation and chemotherapy. So the Mayo protocol is the bedrock of current management of hilar cholangiocarcinoma with regard to liver transplantation. These patients who are unresectable, deemed unresectable by in most groups, in a multidisciplinary group where oncologists, transplant surgeons, hepatologists sit down and say that this is technically unresectable or unlikely to achieve R0 resection. And these patients carefully selected, then they undergo external beam radiation along with sensitization with along with 5-FU infusion. The original protocol gives intrabiliary chemotherapy where iridium wires, excuse me, are passed into the transhepatically into the hilum, into the bile duct to give local radiotherapy. This is very not commonly followed at ATAT centers. This is often replaced by an external boost of another 3,000 rads. And once this chemoradiation neoadjuvant protocol is completed, these patients have to continue on oral capecitabine, Xeloda, till the time of transplantation. And one important part of this protocol is operative staging. Before these patients are actually activated on the transplant list, they have to undergo a staging procedure to make sure that there is no extrahepatic disease. So most often it's either a small laparotomy or a laparoscopy or robotic these days. We go and specifically sample lymph nodes prior to activating them on the liver transplant list. In the US, once this stage is achieved, their MELD is actually low, but they get these extra points where they can go up to what is called median MELD score at that particular transplant center, -3. And so they get an easy path to liver transplantation once all these rigorous pathway has been established. Chemoradiation, again, I mentioned this, already mentioned in the previous slide. I'll go on to so the diagnostic criteria for entry into this protocol is we have to show that biopsy is positive, but this is only possible in 1/3 of cases. So when we have a positive or a suspicious cytology, this must be corroborated by presence of a mass lesion in the hilum, less than 3 centimeters in size, or associated CA19-9 greater than 100 units in the absence of cholangitis, because cholangitis can itself drive the CA19-9. So in the absence of cholangitis, if there is malignant appearing stricture with suspicious cytology that would still pass for a liver transplant. And two important points I wanted to highlight here, right in the asterisk, very crucial for this protocol is these patients cannot have any transperitoneal biopsy of the tumor because this has been shown to cause seeding and adverse outcomes with chemoradiation protocol. Even after transplantation, these patients have done poorly. So transperitoneal biopsy of this tumor by radiology percutaneously is absolutely forbidden if you are considering the chemoradiation protocol and transplantation. Other important thing is before starting on this pathway, they have to have endoscopic ultrasound with FNA of the hilar and any enlarged lymph nodes in the area to prove that these nodes are negative prior to embarking on this rigorous protocol. Staging operation, as I mentioned, is a very crucial part. Once chemoradiation is completed, the laparotomy, mini laparotomy, nodes along the proper hepatic artery, the classic lymph node, which is sitting on the hepatic artery, just about where the GDA takes off, plus the lymph nodes along the portal vein and the bile duct on the right margin. These are routinely excised, and we have to prove that these are negative prior to activating them on the transplant list. Transplant surgery steps, I'll just highlight a couple of few important points as far as transplant is concerned. Because these patients have received chemoradiation, there's a lot of scarring in the hilum. Hilar dissection is typically avoided in order to get in order to avoid any spillage if possible. Excuse me. The portal vein is divided as low as possible. Sometimes in living donor where the portal vein from the donor is very short, interposition graft may need to be required, may have to be placed to make this possible. And at our center and many centers, we follow the principle that we don't use the native hepatic artery because it is in the irradiated field and more susceptible to stricturing and thrombosis. So we always do an aortic conduit. That is, we take the blood supply directly from the aorta. Caudate lobe extension, if this is shown on imaging, IVC has to be removed. That is, again, the piggyback is not recommended in those instances. Bile duct, if the margin is positive, unfortunately, Whipples has to be added at the time of transplantation, but the outcomes are not great. But this is something we routinely do at the time of transplant. So for those in the audience who are not transplant surgeons, this is a classic liver transplant. This is a posterior view where the cava, the liver comes with the donor liver's cava is implanted. The native cava has been removed. This is caval replacement technique. This has to be used when the caudate lobe is involved in hilar cholangiocarcinoma. Versus this technique, which is piggyback, where native cava can be left behind if there is no tumor in the caudate lobe. And the bottom cartoon is about aortic conduit. So this is aorta. Most often we take from the infrarenal aorta, put a cross clamp, we put in a cadaver diseased vessel and hook it up to the hepatic artery of the liver. So occasionally it's supraceliac. Very rarely iliac is used in these instances. But basically the inflow is away from the irradiated field. That's the bottom line. Mayo data 2012, but this has been, I brought this up to discuss how with this rigorous selection, they discussed 215 patients who started on this therapy, but only 136 ended up getting the liver transplant. There's a significant dropout rate in these patients because of side effects, because of finding disease outside the liver during the chemoradiation protocol. So this is a Kaplan-Meier curve. Again, intention to treat. If we include all the patients who are entered, not just those transplanted, even then at 5 years, 56% survival rate, which is acceptable for a liver transplant from the point of utilization of a precious graft. Patients survive. If you take only those who are transplanted, then the survival goes up to 72%, which is really commendable, higher than even what we see with alcoholics and PBC and other liver diseases. So the proof of the pudding is that if one center shows it, that's not sufficient. It had to be proved in a multi-center fashion. So this is where a second study was conducted, multi-center study of using the same Mayo protocol in 12 centers. 287 patients were enrolled, and the results are very similar, slight tad bit lower, but not vastly different. Despite it being done in 12 centers, the 5-year survival rate with intention to treat was 53%. And if you take only the transplanted patients, against stood at 65%. Very commendable for this particularly fatal disease. So importance of patient selection cannot be overemphasized. This is not for every patient that comes. The factors that increase recurrence and poor outcomes after liver transplant are going to be if the tumor size, circumferential tumor size is greater than 3 centimeters, or metastatic disease, which we talked about, or if there's been direct tumor biopsy, this bodes poorly for the long-term prognosis. Past history of malignancy, any malignancy within the past 5 years, again, was an adverse prognostic factor. So in order to come to some sort of consensus, oncologists from MD Anderson, then the Mayo Group surgeons, then Nagino from Japan, from Nagoya University, they all had a consensus meeting about 5-6 years ago, and this is published in HPV Surgery. Essentially, I'll just read out the statements, which I think are very valuable to us. Pathological confirmation is not required prior to proceeding with attempted resection or initiation of a liver transplant protocol, provided other etiologies have been excluded and a complete staging evaluation has been done. Then percutaneous or laparoscopic biopsy of the primary tumor is not recommended. In fact, contraindicated in patients who may be candidates for transplantation just because of the high risk of dissemination of this disease. Dissection of involved intra and extrahepatic bile ducts as well as the liver on that side is the standard of care for all suitable patients outside the setting of PSC, because PSC patients will not tolerate a liver resection. Liver transplantation following a standardized protocol, including external beam, radiation, transluminal radiation, along with systemic chemotherapy, is standard of care for both unresectable hilar cholangiocarcinoma as well as hilar cholangiocarcinoma arising in the setting of PSC. So I'll summarize what all I discussed so far. Essentially, perihilar cholangiocarcinoma, only about less than a third meet resectability criteria. And those who undergo resection, even in most skilled surgical centers, the survival has stood at 40% at 5 years with a great deal of selection. Cause of failure is largely local. So neoadjuvant strategies to sterilize the tumor outside of the duct appear to be effective. And neoadjuvant therapy followed by transplant appears to significantly improve survival and local recurrence with very careful selection of these potential recipients. So important protocols, again, to re-emphasize, is size less than 3 centimeters, no lymph node disease, no mets outside the liver, avoiding transperitoneal biopsy, staging laparotomy, and for a de novo perihilar cholangiocarcinoma, resection is still the modality of treatment. If this is not possible, then consider for this Mayo protocol. For patients with PSC, they have no option but possibly to get into this chemoradiation protocol with transplantation. I'll stop here, and this is the montage of the JIPMER front gate, which is non-existent in my days, and the lower cartoon is about the center where I work at Duke University. My email is mentioned in this slide. Please feel free to reach out to me. My mantra in life has been festina lente. This is a Latin term which says make haste slowly. It's sort of controversial, but it's sort of contradictory in many ways. But it says the best way to make progress is to slow down and take things in a relaxed and deliberate pace. And we actually make good progress there. I'll stop here and stop sharing my screen, and happy to answer any questions. Before I complete, I would like to particularly thank Vishnu for inviting me to give this lecture, and Srinath and Shivam, who are here, good friends, and I really applaud what all they have achieved in their life. And Dr. AK, who was earlier, if he's still there, kudos to you, sir, for training such, giving us all the training we required surgically and otherwise to get on with our lives. Thank you so much. I'll stop here.
Nice talk, Ravi. Enjoyed listening to you after a long time.
Thank you, sir. We are all here. We cannot sing enough praises about you, and it's really an honor to see you and what all you trained, and hope to come and meet you in person in the next within the next couple of years.
I hope to be there in summer. Perhaps I'll come and meet you sometime.
Oh, sure, sir. Please, definitely.
Thank you, Dr. Ravindra. This is Dr. Sendil here. Such a lucid and comprehensive talk on covering all aspects of very difficult tumor, hyalocholangio. A couple of comments. One is in India, it's not picked up big time, mainly for this reason, because it's very difficult to provide neoadjuvant therapy in the required sequence and then do an LDLT, because in LDLT we always fall short of arteries and portal veins, and the risk of vascular company very high. In DDLT situation, at least you have the benefit of having long veins and arteries and KEVA also. That is not available in LDLT, and that's why it's not picked up in India. I only know of a handful of cases being done in Dr. Soin's unit in Delhi, and I'm not sure whether Dr. Dela's unit has any cases. So that's the main reason. But and DDLT, it's not the donation rates are not that very good in India, not matching to the requirements. That's one point. Secondly, the other point I want to tell you was about the downstaging protocol itself, the neoadjuvant protocol. There are slight variations from Mayo also, which are equally successful as well. And the question I want to ask you is that with the advent of immunotherapy, do you foresee it playing a major role in the neoadjuvant, or are you aware of any centers doing trials including neoadjuvant, including immunotherapy as part of the neoadjuvant protocol? Thanks.
Yeah. Thank you again, Sendil. I wanted to again acknowledge the 3 talks I heard from transplant surgeons from JIPMER, Sendil, Rajnikant and Rajesh. You guys have, taken it to the next level, man. I have to congratulate you on all that you're doing. And the living donor liver transplantation, I think India is far ahead of the US. I'm honestly saying this because here 95% of liver transplants are cadaveric, only 5% are living donor. And I visited with Soin last year, the Soin Center, to learn robotic donors procedure. And it's actually the reverse in India. 95% are living donor, 5% only are cadaver. The huge pool of cadaver donors that is not being tapped into, despite over 10,000 deaths on in the highways now that are happening. This is one area, but you guys are doing fantastic work, and probably I look forward to visiting you in Chennai and learning from you, because 2 of our fellows who trained with us 7 years ago, Gaurav Chaubal and Aditya Nanavati, they are the leading transplant surgeons in Mumbai now, and they have taught me a lot. They trained with us just barely 8 years ago, and they have done dual liver transplants in kids, pediatric liver transplants in neonates, as well as living donors bowel transplants. So I applaud the progress of transplantation by young folks like you. And really, coming to the question, there are variations of the Mayo protocol, but Mayo protocol has been the most widely tested in a multi-center fashion and has withstood the test of time, and it seems to work for us. Second thing is regarding immunotherapy. It is still very experimental, and it doesn't seem to somehow make a mark in cholangiocarcinoma, unlike in hepatomas, which you were talking about, which was being briefly. So I'm not aware of any randomized trials ongoing on this particular aspect with hilar cholangiocarcinoma.
Thank you. Just to one more comment. Tom Starzl, the father of transplant, he had a series of about 9 patients, if I remember correct, on cholangiocarcinomas, whom he tried to transplant, doing quite radical, surgically very radical approach. He resected the stomach, the pancreas, and did a combined liver pancreas and liver stomach also in some of the cases. And all of them failed miserably because of one reason: they didn't have the neoadjuvant support at that time. And none of them survived 1 year. We had about 9 patients, if I remember correct. And I mean, that shows again that the importance of neoadjuvant protocol.
You're absolutely right. That's the problem. As surgeons, we think surgery is going to, we can get all the disease if you go wide enough. But unfortunately, we end up actually spreading the disease a little more because we spill the tumor cells we cannot see. And that is the lesson we have learned. That's why one of the important parts is that percutaneous biopsy of these tumors is forbidden. because there will be spillage of tumors, especially when you're needling something in the hilum of liver. Something is going to spill out, and that's adverse prognostic factor for a transplant pathway.
Thank you.
So why this Mayo's protocol is almost non-existent outside USA, and in Japan almost no for this.
So I think they've been it is being used now in Europe, and again the one thing Vishnu is that this disease is not common. Progress in this has been so slow. Unlike hepatocellular cancer, because of viral hepatitis B and C, we see thousands of cases. But even in big countries like India, hilar cholangiocarcinoma is not common. So the adoption and any center to gain significant experience is very, very slow. Even in Mayo, it took nearly 20 years to crystallize these thoughts, and build up a successful protocol and identify this. So that's, I think, one of the major reasons why it is not being widely adopted. Most centers don't have a sufficient number of patients to feel comfortable with this.
Sir, I am Dr. Muthu here. I have a question. Not with respect to transplant, in resectable hilar cholangio, do you see any role of neoadjuvant chemoradiation to improve survival?
That has been talked about, but I think one of the fears is, that has been widely applied for pancreatic cancer, for example, pretty successfully. Again, the experience with this, even in MSKCC and others, has been very slow to come because volumes are low. By the time they present, it's late. They've got jaundice going on, cholangitis going on. They're not very good candidates for applying neoadjuvant pathway at that point of time. And so this has not been very widely studied. You have a very valid point. Potentially, it could reduce seeding when we actually operate, spilling tumor cells from lymphatics and other structures. But again, we are dealing with low remnant volumes in these patients. So how is that going to impact if you have to do an extended resection, right or left trisectionectomy? That may be impacted by neoadjuvant protocols. So these are some of the concerns about that pathway.
Thank you, sir.
Thank you, sir. That was an excellent lecture. On behalf of the Department of Surgery, I would like to extend a sincere thanks to you for joining and giving an excellent lecture. So thank you very much. I think because of lack of time, we are stopping this ALUMNI meet CME now and going for a dinner at 8 o'clock. Thank you very much. And we are closing.
Thank you. Thank you again, Vishnu. Talk to you soon. Okay. Take care. Bye-bye.
So, Dr. Bagadi sir, if you want to speak just one line, you can go ahead. We are dispersing actually. I'm very sorry for that. Thank you all. We are stopping.
Thank you, Dr. Vishnu Prasad. It was a great meeting and I enjoyed very much. Bye-bye.